Dr. Shekhar Patil and Dr. Bilimaga. And I would request Dr. Raghavan also to be on the dais to start the proceedings and invite the speakers. Thank you.
Good morning all. It's a pleasure and honor to be here. I really appreciate the SOGO team for putting up such a fantastic program. We start our first session. People are walking in. So we are going to talk about metastatic prostate cancer as a first session for SOGOCON. And can I invite Dr. Ravindran to talk about the potential of triplet or doublet therapy in CSPC, the pros and cons of it. Dr. Ravindran, please. Oh, he's online. Okay. Can you project the online? We have a mixed program where we have both online recorded sessions as well as live presentations. So because the faculty are from every part of the world and therefore we have made sure that they are, the good news or good message comes across irrespective of where the faculty is placed. So you're going to have some presentations directly as well as the Zoom recording as well.
Hi, my name is Ravi Kantiswaran. I'm a medical oncologist from the National Cancer Centre, Singapore. And my research interest includes in the field of geriatric oncology and genitourinary cancers. I'm grateful to the organizers of the Society of Genitourinary Oncology, India, for this very kind invitation to SOGOCON 2022. Today I'll speak to you about the potential of triplet over doublet therapy in MCSPC, the pros and cons. I'll try to wrap this up within the 10 minutes that's given to me. These are my disclosures. The outline of my talk today would include an overview of systemic therapy in metastatic prostate cancer, specifically in CSPC, and then I'll summarize the current treatment landscape, followed by a slight dive into doublet versus triplet combinations, the pros and cons, and I'll summarize at the end. So systemic treatment in prostate cancer in 2022 has seen a slew of drugs come in over the last decade. Specifically, over the last year, we have seen what is called triplet regimens come into the space of metastatic hormone-sensitive prostate cancer, otherwise also known as castration-sensitive prostate cancer. The two key trials that I will discuss shortly would include PEACE-1, which saw abiraterone, estate, and PrEP plus docetaxel plus ADT, and the next one would be Arasens, which was darolutamide plus docetaxel plus ADT. Prior to that, there was another triplet regimen that was looked at as part of the ENZAMET study, and I'll briefly touch on that as well. Now, the standards of care in MHSPC has seen vast changes, especially as I mentioned over the last 7 years since treatment intensification, initially starting with chemotherapy and then subsequently with novel hormonal agents like ABI, APA, ENZA, and most recently triplet combinations with PEACE-1 and Arasens coming into the picture. All these studies have shown an improvement in overall survival. Really a far cry from the initial days when, thanks to Professor Charles Huggins in 1941, the discovery of ADT made a huge difference to the management of metastatic prostate cancer patients. But it took about 50 years before more development was seen with the addition of bicalutamide and then, of course, all the new drugs that I mentioned to you. Now, I'm just going to summarize some of the more commonly known data, which is the use of ADT plus docetaxel in the Chartered and Stampede study that established that combination as standard of care about 7 years ago. As you can see, the hazard ratio for those studies were about 0.72 to 0.76, implying about a 25 to 30% reduction in mortality. However, when the other novel hormonal agents like ABI, EPA, and ENZA came into the picture, the hazard ratios seem to have improved. However, I need to caution about comparing these head-to-head. So in general, these were the standards of care until triplet regimen came into the picture. So this would be what is considered doublet therapy. Now, in terms of safety of those therapies, as you can see here, the hormonal therapies are very well tolerated. If you look at grade 3 and 4 AEs, in general, they're just slightly more than what you would see with ADT alone. And in general, most of these patients do not need to discontinue therapy, and very few, if any, of these patients actually have AEs leading to death, as noted down here. So now let's go to the triplet regimens. In fact, the first of these was briefly mentioned and studied as part of the ENZA-MET study. So in this study, patients were randomized to receive ENZA plus ADT plus testosterone suppression, a bit different from some of the other novel hormonal agent therapies, clinical trials. And the other group just had non-steroidal anti-androgens, and these included bicalutamide, nilutamide, and flutamide, plus testosterone suppression or ADT. And patients were stratified by disease volume, use of early docetaxel, and that is probably the subgroup of interest which I'm going to discuss today. Overall survival, this was just updated recently in ASCO 2022, confirmed the benefit of enzalutamide plus androgen suppression versus just androgen suppression plus the older anti-androgens as mentioned earlier. However, what was interesting was when we looked at patients who had early docetaxel together with enzalutamide and ADT, the group that had synchronous high volume disease, as noted on your left upper corner there with the circle, which is the gray line, which is ENZA plus docetaxel plus ADT, seems to be the only group that has seen any form of benefit from the triplet regimen. So early signs now, as we know, based on the most recent presentation of an update of this study, did show that the triplet benefited specifically the de novo or synchronous high volume patients. Now let's go back a year to piece 1. This was presented at ASCO last year for the first time. This was a very nicely done study where patients were randomized in a 1-to-1-to-1 fashion and into 4 different groups, standard of care, which changed over a period of time. In the earlier days, it was just ADT alone, and subsequently, in the last bit of patients who were recruited from about 2015 onwards, they also received chemotherapy as well. So it was ADT plus chemotherapy that was standard of care. Other groups included standard of care plus ABI, standard of care plus radiotherapy, and combination of all 3 as the last arm. However, data on the arm that received radiotherapy is not mature yet. So in the first data that came out about a year ago, this study showed radiographic progression-free survival benefit for the combination of ADT plus docetaxel, which plus abiraterone as well. And not long after, at ESMO 2021, the overall survival data, mature overall survival data was presented, which showed benefit for the triplet regimen as well, with a hazard ratio of 0.75, favoring ADT plus docetaxel, plus minus RT, of course, and that data is still not out. Now, an interesting part about that study, when they looked at OS by disease volume, it was quite clear that patients who had high volume seemed to benefit more than patients who had low volume from the triplet combination as shown here, with a hazard ratio of 0.72 for those in high volume patients, while those in low volume, the 95% confidence interval crossed 1 with a much higher hazard ratio of 0.83 as well. Hence, Dr. Fizazi, in that particular presentation, presented this triplet combination as the new standard of care. And you look at it, if you compare it with ABI or docetaxel, and definitely with ADT alone, there's clearly a significant increase in the overall survival for this group of patients. Now, so people were waiting for another study to consolidate on this triplet regimen. And very soon after, you had the study of Arasens, which is Daro plus docetaxel plus ADT, versus just docetaxel plus ADT. In this study, patients were not classified by disease volume, although I gather from the authors that they are looking at stratifying patients by disease volume as per Arasens. But in this study, they were classified by site of metastasis, including regional lymph nodes, or bone mets, or 1C, which was visceral metastasis. And bulk of patients had bone or visceral metastasis. And most of the patients were de novo as well, as noted by M1 disease at initial diagnosis. Now, it didn't matter whether they had de novo or recurrent disease, both groups seemed to benefit. However, those with recurrent disease formed just a small proportion of patients in the study. Now, the key thing about triplet of concern is that people were worried that maybe there are more toxicities. Nevertheless, you can see most of the toxicities in these studies were reported due to the docetaxel and not really very much added on to the ADT as noted here. So if you look at serious adverse events, really not very different. So the darolutamide did not add that much more toxicity to the doublet combination. Now, in the real world, the reality is people are not even getting doublets. So if you look at data out of the US from numerous databases, including Medicare, Concert AI, Optum, for example, between a third to half of the patients do not receive treatment intensification. Of course, we can say that some of these studies were a bit older because these databases were analyzed in 2018 and 2019, and perhaps more patients are getting treatment intensified right now. Nevertheless, when you look at guidelines, and we published this earlier this year, including some of the medical oncologists from India as well who were part of that group, clearly the strategy includes using triplet, doublet, but treatment intensification is key unless patients are very frail. And at that point in time, we had the PEACE-1 data, so docetaxel is there, but with AAP, with AbbVie, but darolutamide data is not there because Arasens was published later after this came out. Now, how do I give triple therapy and who do I give it to? So firstly, I'll give it to de novo metastatic CSPC patients. So that's where the data seems to lie at this point. Apart from the small subgroup in Arasens, they must be high volume and fit for chemo. They will get triplet. Any other group who are unfit for chemo or low volume will just get ADT plus NHT. Of course, those who are very, very frail will just get ADT alone. So there are numerous treatment options now available for advanced prostate cancer management. Most patients should get additional therapy or what is called treatment intensification. The choice of doublet or triplet will depend on the following factors. De novo metastatic disease seems to be where the data is at right now, high volume, and they must be fit to receive chemotherapy. Now, the unanswered question here is, of course, what is the additional benefit of chemo to ADT plus NHT? And that's something that's going to be difficult to study because the ADT plus chemo studies came out first, hence NHT was the add-on in all those triplet regimens. And if so, which group will benefit? With that, I thank you very much.
Thank you so much, Doctor. Thank you. Really appreciate your time. This presentation is open for questions. Yeah. Hi, sir.
Hi, good morning. Hi, Kiswan. This is a good presentation. My question is, you use sort of triplet or all that sort of options in the first go. When the patients relapse, do you have anything in your kitty? You exhaust all your options.
Yeah, no, that's an excellent question. Can you hear me?
Yeah, we can.
Yeah. So I think sequencing is the challenge we have right now, because now if we throw the whole kitchen sink with triplet, what do we think of next? I think clearly, firstly, if you look at hormonal therapy, based on data that we have, it wouldn't be wise to go to a second-line novel hormonal agent. Meaning if you use darolutamide or abiraterone or even Enza as per Enzamet with chemo plus ADT in the first line, you wouldn't go to the other drug in the second line, other oral tablet. Although we do see this happening even in the US in community practices. The reason for that is because your responses are going to be poor. So what are we left with? Now, you could go on to another line of chemotherapy. So cabazitaxel is an option. At the point they're progressing and becoming castrate resistant, because that's where you will be once you're done with the triplet combination and you're progressing, probably a good idea to actually look for DDR mutations, DNA repair gene mutations, including BRCA1, 2, and ATM, and explore the option of PARP inhibitor like olaparib. However, we know that the chance of picking up these mutations is going to be uncommon. It's 1 in 5, or about 20% of the patients harboring somatic and or germline mutations. Now, the other option would be theranostics. So PSMA lutetium would be where some of the data lies right now as well, after a few trials have come out, including therapy and vision. So we still have options. So you have second-line chemo, you have olaparib, you have theranostics like lutetium PSMA, and they're more in the pipeline. They're being studied and maybe potential options as well.
Yeah, the point I was making is well said. Point I was making is rather than exhausting all the options in the upfront, either you can have a combination of chemo and ADT, or AB and ADT, or sort of enza and ADT, followed by reserve the other things for the second line. That's what point I was making.
Oh no, that's a good point. The only thing is, if you look at how these trials were designed, Arisons and PEACE-1, the comparator arm was ADT and chemo. So
The SOC has moved to the ADT with chemo now.
Yeah.
Yeah. So what that tells you is that giving all three upfront does add to survival of these patients. So, and many patients will drop out. We always want to give our best options in the first line, especially if it's proven to improve survival, because we have no guarantee that some of them will, get the second or third line and thereon. Yeah. So that's why I think with the right patient selection, triplet therapy will be the way forward. De novo, high volume patients, metastatic patients should be considered for triplet therapy as long as they're fit for chemotherapy.
Sure.
Thank you, sir. Sendil, sir.
Hi Ravi, good morning. How are you?
Hi,
Good to see you.
Sindhu. All good.
Okay. So one question: who in your practice now gets ADT plus docetaxel?
Very few.
And who are those few?
So those, firstly, they must be fit for chemotherapy. And up to maybe 2-3 years ago, because cost of the novel hormonal agents was high, so they were those who could not afford those agents as well. But I would give those who have visceral metastasis, and especially if I think further down the line, they may not be able to tolerate chemotherapy. Because if these patients progress and they got high volume, so high volume, those with visceral mets like in the liver, I would actually want to give them upfront ADT plus chemo, because they may miss that opportunity, further down the line. So there are a few, and those will be the few.
So essentially, it's somebody who can't get the new anti-hormonal agents. Is that right?
Yes, and also somebody I think may not get the opportunity for chemo later
so
on.
anyway, they would go on a triplet right away, isn't it?
It's possible.
Thanks.
Yeah.
Dr. Vineet.
Hi, Dr. Ravi, how are you?
Hi, Dr. Vidit. Hi.
Just a simple question. Between ABI and ENZA, frontline, which one would you choose?
Excellent question as well, and I think that's also a pharmacoeconomic question, because ABI is generic and it's a lot cheaper and affordable. So I would go by patients' comorbidities. Because of the way our reimbursement is in Singapore as well, ABI is very cheap. In fact, it's nearly free. So that will be the default choice unless patient cannot tolerate it, which means they have uncontrolled diabetes and the prednisolone will make it worse. They have uncontrolled hypertension, maybe even cardiac failure, where the fluid retention will make it worse, and blood pressure control may be a problem. So for these groups of patients, all related to drug interaction reasons, I would choose one or the other. So comorbidities and drug interactions are the two factors that I would
Steroids
look
would
at.
be a dampener, right?
Steroids generally would be a dampener, because these patients get a lot of steroids with chemo and with this as well, and definitely with diabetics, it does cause major problems.
Thank you.
Thank you. Last question.
Cases of triplet therapy, is there any role of re-challenge of docetaxel after a long convalescence period, like the disease was controlled and after say 2 years or 3 years when the patient is on abiraterone, he again have a recurrence of disease. So initially there was a role of re-challenge with docetaxel.
Yeah.
So is there any role of re-challenge with docetaxel in triplet therapy, or we are left only with the cabazitaxel or PARP inhibitor?
No, it's a good question. Now, a lot of data in the re-challenge docetaxel space came about because we didn't have good second-line therapies at that point in time. So this was pre-cabazitaxel days. Now the challenge is cost as well. But docetaxel is a lot cheaper than cabazitaxel, which is still on patent, at least in a lot of countries that I know. So my answer to you is, if cost is a challenge, but patient had responded well initially, and now it's been a while since, you can always re-challenge with docetaxel. I think it's not unreasonable to, even when patients have progressed on ABI as per piece 1, then you just get them on the next chemo, which can be docetaxel. But if cabazitaxel is available and cost is not an issue, I would go with cabazitaxel or lutetium, for example, as the next
And
one.
in that condition, you will like to discontinue the abiraterone or enzalutamide, whatever you have given in the initial triplet combination?
Yeah, absolutely, because if patients had progressed while on maintenance ABI or Enza or Daro, then obviously the disease is resistant to it. So continuing it will just add on to the toxicity without providing any benefit. So I will stop it and just get on to the next line immediately, which is any one of the chemos or lutetium or PARP inhibitor if they are suitable.
What are the numbers of docetaxel cycle in cases of triplet therapy combination? Usually we give around eight cycles. So you give
no,
eight?
it's six. No, it's 6 cycles in the triplet. Yeah.
Thank you so much. Thanks for joining in from Singapore. Really appreciate.
Thank you. Thank you for having me. I'm sorry I couldn't be there in person, but I wish you all the best for your conference, and thank you.
We will have you next time for sure.
Okay, bye-bye.
Thank you. So we'll invite Dr. Jiten, our own boy. He has come all the way back from London. Really appreciate your time and effort here. He is a senior clinical fellow, but he also happens to be a consultant in Rajiv Gandhi as well. So before you start, Jiten, a few points. For the international presentation, it's going to be 4 questions. For national presentation, it's going to be 2 questions. And please note the questions because all the faculty are available here. The idea of SOGOCON is interaction. We will encourage interaction. But at the same time, we need to push the time as well. And the request to the presenters to strictly stick with the time as well. Thank you so much. And a few points before I close with this topic. 90% of my metastatic prostate cancer goes for docetaxel. So I'm not very convinced that patients are not fit for docetaxel. Almost all patients seems to be fit for docetaxel in HSPC status. Second thing, between abiraterone and enzalutamide, I have observed that enzalutamide causes a lot more side effects, much more than what we are told, especially neurological side effects, and they almost become wheelchair bound. At least few of my patients have become wheelchair bound, not able to move with enzalutamide therapy, which is not reversible. So with those little thoughts, we'll invite Jiten to start his presentation.
Good morning and greetings from Imperial Urology. I have a lot to cover in 10 minutes, and practically what I'm going to do is, is a module as a part of a semester course in cancer research. So if you be with me 80% of the time and only 20% of the time with the slides, then you will follow along well because there is a lot of ground to cover, and I'll be going a bit fast because I have less time. So today I will be talking about endpoints in studies of metastatic prostate cancer to see if we can serve patients better. We will build a conceptual understanding of endpoints and understand the necessary statistical nuances and pitfalls, and then put everything together in a clinical context, and then identify lacunae in literature and aspects which need more research. Trust me, by the end of it, you will begin seeing through the trials and start correctly reading in between lines, and a lot of questions that were just asked would just disappear. So let us understand the core concepts first. A clinical endpoint is an objective tool used to measure how beneficial a medical intervention is to a patient's feeling, function, and survival. Now, obviously, all 3 of them, keep the patient at the center, and the historical gold standards have been overall survival and health-related quality of life. Now, there are problems if we look at each endpoint in isolation. So the obvious problem with OS is that due to the natural history of prostate cancer being very long, it often necessitates studies of a large number of patients over long duration of time to correctly identify an endpoint being reached. And the second aspect is that not every aspect of patient's experience is captured in just estimating his overall survival. There are also problems with QOL when seen in isolation, and that is that patients can be, minimally symptomatic to very symptomatic during the course of their cancer journey, and preserving QOL versus improving QOL are entirely different game plans. So if we look at the influence of time on these aspects, that's another, game altogether. So, for example, let's understand with a wrong example first. Say we have patients with oligometastatic prostate cancer, and we start with them, on ADT and compare it to placebo. Now, initially, since these patients are asymptomatic or minimally symptomatic, the ADT arm will experience a loss of QOL, right? The QOL will go down. But then it is only after progression of disease that you will begin seeing that, yes, ADT does help improve QOL as well as survival. So, if you specify the trial design itself to be wrong, then these endpoints will not prevent you or save you from going in a wrong direction. These don't guide you. Your trial design has to be in accordance with clinical science, and it must be in agreement with scientific theory. So never ever analyze OS and QOL in isolation. So that brings us to the idea of surrogate endpoint. It would be absolutely lovely if we could find a biomarker which could act as a substitute for the clinical endpoint, and obviously then we can, accelerate novel drug treatment approvals. So by design, a surrogate endpoint has to occur before a patient will experience a change in feeling, function, or survival. So by definition itself, a surrogate endpoint will have to be tumor-centered, because patient is yet to experience things or, any of those feeling, function, or survival. So it is not going to be patient-centered at all. So there are multiple surrogate candidates across the cancer field, but FDA approves almost none of them for prostate cancer. And to understand why, we need to understand certain statistical nuances. Now, Prentice laid down certain criteria for surrogacy, and let's understand it with the example of PSA, which is again a wrong example. So a surrogate must be associated with cancer, which PSA is. Of course, you have high PSA, you may have cancer, though not necessarily. The treatment must be associated with the surrogate endpoint. Yes, you have a successful treatment, the PSA does come down. But the surrogate must mediate the association between treatment and cancer. And now here PSA has problems, because a high PSA does not kill the patient or does not do anything to the disease pathophysiology. And sometimes we see PSA only progression, while clinically and radiographically the patient is not progressing. So this is not met. Let's look at one more essential condition which must be satisfied, and that is that surrogate endpoint must ultimately be validated. So if we look at PFS, we often see that, in trials you see that a drug improves the progression-free survival, but overall survival is not improved. This can be due to multiple reasons. Say, for example, you gave first-line therapy, but then there is so many second or third-line therapies that extend the survival so much that the effect is on the final outcome of OS is not really seen. Or, for example, the PFS is improved, but later on patients die due to comorbidities or other competing causes of death. And again, ultimately, you don't see the overall survival being true. So there is a lot that can go wrong with surrogate endpoints. And if you're really interested, you can go through an excellent paper by Fleming et al. About all these mechanisms, which can, lead you in a wrong direction with the surrogate endpoint. So what else do we want to see in a good survival analysis? We want to see that the median survival is reached. Now, there can be two reasons. Say, suppose in the first graph, you don't see the median survival being reached, and ultimately that would have been the true picture, and you missed the true effect, and you just said the treatments are not useful. While in the second picture, you think that the treatments are useful, median survival is not reached, but later on the curves cross because delayed cumulative toxicity due to the drug happens, or other competing causes play in. So again, disease picture is not completely captured. So, but reading median endpoint also gives a hint that we adequately first powered the study and also followed up the patients adequately in time. And it also means that we had sufficient time to study the adverse effect of treatment. So that's why it's important. The second important thing is always look at censoring in survival graphs. So censorings are those whiskers that you see on survival curves. And we want to be sure that there is not a lot of censoring happening before the median survival endpoint is reached. Why? Because sometimes, censoring basically means something other than the outcome of interest happened and the patient dropped out. It could be anything. So if a lot of censoring happened despite the blue arm being better before the median survival was reached, it could have been that the drug was very toxic and intolerable, patients simply dropped out. So even though the PFS was improving, this is not a good drug. So again, chart simply misleads you. So now that you have some theoretical understanding, let's put everything together. So most obvious aspect to consider whenever you start thinking about an endpoint is, in a study, how ultimately away from death are we? So if we are close to death, which happens in metastatic CRPC setting, then you really do not need to go for a surrogate endpoint, because you will have enough number of patients who will reach the ultimate endpoint, and there would not be any risk of competing causes of death or comorbidities playing in, because the time to that event is less. So OS and QOL by default, even without doing any thinking, they would be an obvious endpoint for MCRPC. Now, surrogate endpoints become important if we are early in the disease course, of course, because we want to beat the time lag. And if we learn something from the example of NMCRPC, and a part of it was covered by my previous speaker, so a very good thing happened in the Spartans trial. What the investigators did was they were studying NMCRPC, and the proof was that will adding novel anti-androgen help. So what they did was they chose metastasis-free survival but not overall survival, because it met all the Prentice criteria. But they did something very, very smart, which was unique. What they did was they only chose patients whose PSA doubling time was less than 10 months. Why they did this was because they wanted patients on an accelerated disease trajectory who were going to quickly reach the endpoint, so that they can then prove it, early. So this was the only reason they chose this. So it does not mean that PSA DT more than 10, this thing might not work. It might work, we don't know. But to establish the proof of concept soon enough in time, they chose this. So this gave them a smart statistical edge. Now we can, if we talk about HSPC, the logically only surrogate endpoint we would have is progression-free survival, because MET has already happened. So can we learn lessons from the NMCRPC story and apply it to HSPC? Yes, and my previous speaker showed it to you. In the triplet therapy, they deliberately chose high volume disease. Why? Because these patients will accelerate towards death, and then we can prove our proof of concept. It does not mean that low volume disease triplet therapy may not work. It may work, we don't know. But to prove the concept, we chose high volume disease, and in RGCI, we did a study where we looked at treatment options and see who died in the first 3 years. We found that patients who had bone pain and received palliative radiation in the first 3 years died more often. So if we choose patients with bone pain and apply HSPC trials and any new treatment idea, it will quickly reach the endpoint. So this is my last part. So if we look at the research teams for all other cancers, overall survival is now coming down as a preferred endpoint for drug approval. But for prostate cancer, this was there till 2011, only OS, and with only 4 exceptions. Only in 2012, they approved metastasis-free survival as a surrogate for localized disease and NMCRPC, and ultimately apalutamide was given approval in 2018. So a lot of effort goes in to validate the surrogate endpoints. We have to gather high-level evidence, then we have to prove association, then we have to quantify the strength of relationship, and this organization called ISCAP does all of it. So in HSPC now, in 2022, we have now meta-analysis level data proving that PFS could be a valid surrogate endpoint. However, in CRPC, like I explained, only OS and HRQOL remain valid endpoints, and you don't even really need a surrogate endpoint there. And the research for composite endpoint continues with AI proving, that there can be even better models to specify. And lastly, there still remains one huge lacuna. The definition of endpoint was never written by patients. This was clinicians deciding, feeling, function, and survival. If you look at individual ideas about, collect in interviews with patients what they really want, they tell a lot. They go through like so many issues that they really want to change in their life. Sometimes they are fussy about decreasing in tumor size as well. So when it comes to individualizing to a patient, Always look at his preference also and factor it in your decisions. So in conclusion, overall survival remains the gold standard endpoints for MCRPC. MFS is a valid surrogate endpoint for localized and NMCRPC. PFS may become a valid surrogate endpoint for HSPC in future. Designing trials by including worst prognostic group patients may accelerate demonstrating the proof of concept. HRQOL should be a co-primary endpoint in every study and analyzed in conjunction with scientific theory. And research on more composite endpoints is needed to better capture patients' experience. Thank you.
Fantastic presentation, Jitin. I was always impressed by what you do. Really nice presentation. It's such a complex topic, and we are very proud that we gave that topic to you, and you did full justice to it. Questions are open for discussion. The landscape of cancer has changed a lot in the last 20 years, especially with prostate. The OS as a marker for survival has now, OS as a marker of our endpoints have now largely moved forward, and Jitin has superbly summarized it. Sir?
Yeah, only words of appreciation, not the words.
Very, very nice. Jitin, so are we going to have the new endpoints, or at least this new concept will be the basis for the future trials? Do you think so?
Yes. So a lot of research is happening right now. So there are a lot of new scientific methods that are being used, Bayesian network meta-analysis and stuff. So it's exactly in 2022 in ASCO and GEO-ASCO, a lot of papers came in which were simply looking at surrogate endpoints. And trust me, the pharma companies are on it. They want every means to approve drugs quickly.
I appreciate it.
Yeah, and all those papers are from them. So.
They have an interest on that.
Yeah. Jitin, brilliant talk, absolutely fantastic talk. What do you think here?
Sorry.
A brilliant talk.
Thank you.
What do you think, now moving, this is CRPC clearly, but a lot of audience would want to know for localized prostate cancer. What would be your view on that, very quickly?
So yes, so ISCAP approved metastasis-free progression survival as a surrogate endpoint. So that would be there. All we need to do is, if we ever want to design a trial, find a worst prognostic group, apply MFS to it, reach endpoint
that
quickly.
is a very good...
Yes, and then prove it later on.
So biochemical failure, are not endpoints. Metastasis-free survival should be the...
Yes, so specific to your point of biochemical failure, so there is a thing called immortal time bias, which is a problem with radiation therapy trials. What happened was, if we choose a nadir endpoint as a beginning point of a trial, let's say if a patient reaches a nadir PSA after radiation therapy long, then by definition he is a good prognosis case. And once you try to apply a trial to that person, the trial begins to fail because you chose a good prognosis case, and then you need to follow even longer. So it's called immortal time bias. That's why any of these failure-free survivals or these kind of things, or nadir survival, and they fail. So you need to, MFS is the answer for localized disease.
I think Stampede has started applying MFS in most of its...
Localized, locally advanced MFS.
Jitin, you alluded briefly to the difference between progression-free and overall survival. And you mentioned that if you've not seen the study through for a longer period, PFS not improving or PFS improving may not actually correspond to the OS. Can you further
elaborate that slide? Yeah, okay. So what happens is PFS is just one step in the pathway, right? So you gave one treatment, PFS improved. But later on, let's say comorbidities came into the picture. So a drug was ADT, and it led to a lot of cardiac toxicity, and patients were elderly, and then they started dying due to cardiac events. So later on, when we followed them, the overall survival endpoint was not reached because despite living initially longer, they later quickly died. The other thing could be, so obviously comorbidities, treatment-related toxicity, competing causes of death, or there could be good second, third line treatment options that despite the first treatment failing to improve PFS significantly, the excellent second and third lines extended the survival so long that the first difference did not matter. So you see, that's why many of these PFS criteria fail. So early in the disease course, maybe you need to see. Or again, like I said, choose a bad prognostic group patient who will accelerate, and then you don't get these issues.
But that will give an innate bias to say that we have chosen the wrong set of patients to do the trial.
So that's exactly, so like one of the, there was a question that why only high volume disease, why not low volume, what about triplet therapy in them? And the next question was what happens if we give doublet and we save something for later? So for a high volume disease, the patient is going to quickly die. You don't have time to introduce 2 drugs and then 3rd drug. So trust me, triplet therapy is the obvious answer. To a statistician, this question will never come. But if you are confused and you don't, in your practice, you see a mix of patients who are good risk, bad risk, then this question comes to the mind. So that's why a bit of understanding of statistics really clears a lot of doubts.
Thank you, Jiten. Really appreciate it, really. We invite the next speaker, Dr. Amit Rautan, for management of metastatic CSPC. So all this discussion, it all started with the charted trial, high risk, low burden, high burden, and then from there onwards, each trial started its own subclassifications as well, whether it's a 3 meds, 4 meds, 5 meds. So the question is, are these things melting away in front of us?
Thank you very much. Good morning, everyone. I thank the SOGOCON team for giving me this opportunity. So, an interesting topic. Management of metastatic CSPC, oligometastatic disease versus low risk versus low burden is the thin ice between these melting away. I read the whole line, and when it was told to me, the first thing I said was not me. I don't want this topic, but eventually it's something that it's a very interesting discussion point. So I think we will take this forward. So let's take this quickly through. First, let's start defining things. What do we mean by each term? So oligometastatic disease, yes, we know this is a disease state. You're talking in between localized prostate cancer, and the other end of the spectrum is widely metastatic prostate cancer. So you have this limited metastasis, and you're calling this oligometastasis. But you still don't have a fixed definition for this. And there are different defining points, but most of them would say it is between 1 to 5 metastatic sites. The metastatic site should be soft tissue or bone only. Also, the temporal pattern has been defined. It could be synchronous or it could be metachronous. And most of these patients are hormone-sensitive prostate cancer. I think the uro-oncology community has actually kind of defined oligometastasis much before than all the other cancer groups. So if you see, we treat all cancers, but oligometastasis in prostate cancer has been a discussion from 1995, from the time they first derived this term and started using it for practice. And this is something that we are moving more and more forward. And now in other cancers, we say oligometastasis is becoming important. But we are learning a lot from this, from the urology community for this group of patients. Now, why is it important? You know these patients will survive better. You see number of lesions. If they have 1 lesion versus number of lesions, the survival is much better. You see location. If they have lymph node mets versus bone mets, and versus visceral mets. Clearly the lymph node mets have the best survival, and then the bone mets, and then the visceral mets. So clearly, this is a group of patients who can have a very extended survival and a potential to cure. We know we are very scared to use cure word in metastatic disease, so we say a potential to cure, and that's what we keep looking at. How can we do best for these patients? Well, we also started using other terminologies. We started talking of low volume disease and also low risk disease. Now the low volume disease comes out maximum from the chartered data set. We said patients who had 4 or more bone metastases and at least one of these metastases were outside the axial skeleton, or you had a visceral metastasis. These are called high volume disease. The rest of this is low volume disease. What about low-risk disease? Now this is, we read more into from the latitude data sets, where you saw the initial trials of abiraterone, where you said if you had more than 2 of these high-risk features, and the high-risk features were greater than 3 or more bone mets, visceral metastasis, high-grade tumors. To 2 out of 3, this is high-risk disease, and the rest of them is low-risk disease. So there's these terminologies which we use, and they are different in different trials, so one needs to be very careful when we look at that. So what's the approach of treating oligometastatic disease? ADT was the systemic therapy you used, but now we always talk of intensification of ADT with combination regimes. And the combination could be chemo, or it could be androgen receptor pathway inhibitor. There's also an important role of local therapy to the primary, and of course there's metastasis directed therapy is important in oligometastatic disease. So intensification with chemo, we saw the chartered data, it was practice changing for us 6 years back. Docetaxel added to ADT in this space showed us a clear improvement in overall survival. Now when they looked at the subgroup of patients, they looked at the high volume versus the low volume, and this is the definition they had created in this, which came out for the first time in clinical use. And what they clearly saw, the high volume patients with docetaxel have a clear improvement in overall survival, and in the low volume, there is no benefit of adding docetaxel. Now, we've also seen data from the STAMPEDE in arm C, that's the arm where they gave chemo. There is equally benefit in the high volume and the low volume. So there's always that dilemma, who do you offer chemo to? But still, when we look at chartered, that's been our practice. Using high volume as the chartered definition, we would offer it to a high volume patients, and low volume, we were not really looking for offering chemotherapy. Now, it's become important that intensification with androgen receptor pathway inhibitor combinations have come into practice. And this was the first data set which we saw when we saw the Latitude data. Now, Latitude used only patients of high-risk metastatic hormone-sensitive prostate cancer. The inclusion criteria had only the high-risk patients. And they had created the definition which I showed you, 2 out of 3 has to be there, and those are the patients which I offered abiraterone plus ADT versus ADT. And they saw improvement in RPFS, there was improvement in overall survival, but they went back and they did a chartered kind of definition of high and low for these subgroup of patients. And what they saw, the high volume has a clear benefit, but the low volume did not have a benefit. But again, one needs to understand this was an analysis which was going back into the data, looking at it in the various, putting the chartered data set into in high and low, and then saying benefit or no benefit. And that's not the way it should have been done. If you want to take it, you should take it to the proper stratification and then look at it prospectively. STAMPEDE is the most, a trial which you can use to explain everything. So any of the metastatic diseases, you want to try to prove whether any benefit is there with DOS-C, or whether you're adding in abiraterone, or whether you're adding it, even abiraterone plus enzalutamide has now come in. So these are arms which have a very, very interesting study by which they kept increasing the arms and the number of patients, trying to answer various questions. But what STAMPEDE has clearly shown us in the arm G, which was looking at adding abiraterone to ADT versus ADT alone, what they saw, clear improvement in the overall population, hazards of 0.6, and we recently saw the updated analysis showing a clear benefit, more than 2.5 years of benefit in terms of overall survival. They looked at the chartered data set. Now they made you did the chartered study, put high and low risk. Here you see a clear benefit of abiraterone even in the low risk and even in the high risk. And if you see the hazards, they're almost the same, 0.53, 0.59. They put the Latitude risk groups, and they again made into high risk and low risk. And again you get the same benefit, 0.55 hazards in both sides, clearly telling us abiraterone is adding to ADT in terms of overall survival, irrespective of whether you saw the overall population, irrespective of saw the volume of disease, or irrespective of you saw risk of disease. I think this trial once clearly answers, the ice has melted away. It's completely gone. We clearly see the benefit in all of it. Well, we've seen recently the other drugs which have come in. We saw the Titan data. This was looking at apalutamide in combination with testosterone androgen suppression. And here we saw, this is the overall population. We had a clear PFS in improvement. We also have an overall survival improvement. And look at the subgroups. They had a stratification where they looked at disease volume. And here we clearly see low volume, high volume, both of them equally benefiting patients by using apalutamide. Enzamet study, we saw this already. Dr. Ravindran showed us excellent data of enzalutamide. Again, clear improvement in PFS OS in the overall population. But when you look at subgroups, low volume, high volume, again, both of them have benefit. We are seeing the benefit there by adding enzalutamide to the ADT. Also, if you look at enzalutamide has the ARCHES study also. ARCHES has a little shorter follow-up, but this was also looking at adding enzalutamide to ADT versus ADT alone. And here we saw radiological PFS endpoints. This is clearly beneficial. And again, they have a subgroup with the stratification of high volume and low volume. And clearly there, again, we see a benefit in terms of RPFS in low volume and high volume. So what we eventually are seeing that in all the studies of adding androgen deprivation therapy plus an androgen receptor pathway inhibitor, let it be abiraterone, enzalutamide, or apalutamide, all of them show a benefit whether it's high or low. So really that distinguishing point has now gone. This is one place where we always talk of local radiotherapy to prostate because of the STAMPEDE data, which clearly showed us again, low volume, there's a clear benefit in overall survival when you add radiation to the prostate. And in the high volume space, we did not see the benefit. I would kind of end saying that we've learned ADT is the systemic therapy for years, and that's what we have been doing. But the era has changed. What we need to understand, ADT plus intensification is now the era for all patients. I don't think we should really distinguish our patients by oligometastatic or by low volume and high volume or low risk and high risk. Everyone receives ADT plus intensification, but yes, the intensification, at least for these low volume, low risk oligometastatic disease, should be by using androgen receptor pathway inhibitors. So using one of these oral drugs, and it can be any of them depending on our comfort, our patient side effect profile, and their financial conditions. It could be ADT plus abiraterone or enzalutamide or apalutamide, and that's the way further. And now we have learned this in different ways. We have learned it where we move to M0 space and we talk about using these drugs. We are talking of using it in patients who have localized high-risk disease. So clearly, in the oligometastatic space, we should not distinguish it, and we should look at this kind of a combination. My last word, the whole science is moving to a different space. What we are looking at and what is being done now, you're looking at oligometastatic disease and doing genomic molecular profiling. And what we are understanding, the biology of a molecular profiling of an oligometastatic is very different from a localized disease versus a distant extensive metastatic disease. And that's the way the science is moving. Can we use this knowledge of having a different molecular subtype for treatment in patients in the future? And it's going to be a very interesting space in future. Thank you very much.
Fabulous talk. Really appreciate that. So, can we just remove all these terminologies and make it into a single, like what we did for bladder cancer into low grade and high grade, just remove all the G's out. Can we just box them into two groups where we have metastatic disease and low volume metastatic disease, and all the low risk and everything comes into one pot? Is that doable?
I think that's the best thing to do.
Because the problem is we have different criteria for different trials, and the one trial investigator is applying the other trial criteria, and other than producing many papers, it doesn't add value to us.
Absolutely.
So
I fully agree. It's so easy to just put one terminology and use that in all trials. But the good thing is, at least now, all the newer trials, they have stratification points of this. But I agree with you. It could be just low volume, high volume, and leave it and use the same thing. The question is always, everyone doesn't agree even with the definition of low volume and high volume. So that becomes again a criteria. But I take your point clearly.
Thank you. Dr. Amlesh, please.
I don't think it can be as simple as that, because in prostate cancer, if there are lymph node metastases, staging wise it is classified as a metastatic disease. But in terms of potential to kill, even if a patient has extensive lymph node metastasis also does not kill the patient. Whereas bony metastasis leading to paraparesis and visceral metastasis leading to significant reduction in appetite and cancer-related cachexia, they are the killers in prostate cancer. So therefore, just to say that high volume disease, we also, I think, need to understand or specify the sites of metastasis, because they are also important in deciding the long-term prognosis.
Thank you, sir. Yeah, appreciate that talk. Dr. Aditya Pradhan.
Yeah, quickly. What have you come across in terms of the adoption of PSMA PET by all of us to define this?
Yes, sir, that's an excellent point. So all these trials, when they defined oligometastatic or low volume, high volume, all have used conventional imaging. They have always been CT scans and then bone scans, and that's how it has been defined. But we clearly know PSMA PET is the way forward, and that's what everyone is kind of using. So what you're seeing in practice, it's being seen in the West, it's also being seen here. Your patients whom you defined as oligometastatic have actually increased. And that's the reason is because you're using more and more of PSMA PET scans. So you're picking up much more of these, which earlier would probably have been M0 in the old definition or in the old imaging criteria. But I'm sure this is going to change, though as of now we still say CT and bone scan is the way, but the way has to change forward. PSMA will become a routine, and everyone is slowly moving to adapting this. But of course, all our clinical trials still don't use these.
Thank you, sir. Thank you so much, Dr. Vitta. Really appreciate that. We are going to skip one, Dr. Sanjay Adla, who is not able to join right now. So next will be the case-based discussion. I invite Dr. Sindhil Rajappa to come invite his panelists and take it forward. Thank you so much. Thanks, SOGO, for this opportunity. Sindhil has given me the enviable task. Can I request Dr. Amlesh Seth, Dr. Makaran, Dr. Arun, Dr. Vinayak Makha, Dr. P.S. Chowdhury, Dr. Abhilash, Dr. Mitua, Dr. Amit to come on stage, please. Can organizers get us more chairs, please? We need 5 more chairs, please. Thanks. Please. Sir, no, sir. Please come, sir. Let's jump across.
No, I've made a list of people already. Okay, we're set. Where is Dr. Raghavan? Oh, please. No, that's fine. You want to join the panel?
I think there is enough stalwarts there, so okay. I'll be here. Thanks.
Sure. Thanks. Good morning, everybody. I'm glad we don't have to ask the question, am I audible and am I visible? Right. So we're finally here offline, and it's lovely to be in the midst of people because that makes you really happy, right? Without wasting any more time, we will go on to this panel discussion on metastatic prostate cancer. I've been given the task of discussing a myriad of things, so I would request the panelists to, give me short answers, crisp answers, so that we can move on and address everything that we have to address. This is where Amit left. So let me start by asking Dr. Makaran, your thoughts on classifying patients. Has it got predictive value? Has it got only prognostic value? What are your thoughts? Because we kind of do this to all patients who walk into our outpatient, isn't it?
I think it's important to know where you stand, and not only from prognostic point of view, but also tailoring the treatment itself. You have to have a roadmap. And as we just discussed before, previously we were soldiering on mainly CT scan and a bone scan. I think almost every town has now PSMA PET scan. So we have to quantify the disease, and that is extremely important, extremely important. Without that, I don't think we can tailor the treatment and actually look at the horoscope, what's going to happen in future.
Right. So as Amit rightly pointed out, from a predictive or from a treatment standpoint, it may not make a big difference, but it's starting to make a difference again with triplet therapy. Ravi spoke about it. We'll address it in a little while. So we started by saying that it's only ADT. And then now we are saying that irrespective of whether it's low volume or high volume, you add some intensification. We'll then say low volume patients may not actually benefit from the addition of docetaxel, but the stampede actually showed that there is some benefit. So that blurred away again. Now we are saying that if it's triplet, you're using it only for the high volume patients. All right. So everybody gets intensification, but how much you intensify is also going to depend on the volume. So it's come back into relevance let's say, from a year ago, again, I was very much like what Amit said. I also thought the blurring had happened and everything went away, but there seems to be some value to it still. The second important is, as Dr. Mankaran rightly pointed out, that you want to also prognosticate your patient. The table that is onto the right side of your screen clearly shows that if you've got somebody who's got metachronous, low volume disease, the overall survival is around 8 years. So we don't clearly know the value of intensification in that group. If you look at all the trials that have been done, the percentage of patients who actually fall into that group is less than 10%, right? So though we intensify for that group also, the value of intensification is not very clear, and rightly Dr. Jitin pointed out, it's almost impossible to get an outcome benefit evidence in, let's say, 10 years or 15 years for that group of patients. So it is still important to classify these patients. From a prognostic standpoint, it is a very strong prognostic factor. 8 years, 4.5 years, and 3 years for your patient makes a lot of difference. But from a treatment standpoint, it kind of blurred off, but it's again coming back with the triplet therapy back in space. Let's quickly discuss this PET scan story before we move ahead. Amit, I want to ask you that question. Do you think we are choosing our patients better by doing a PSMA PET CT scan? Is there stage migration, and what is actually oligometastatic is what you're treating as oligomet now or low volume now, though the trials didn't do that. But do you think that our results are likely to be better when you classify patients by a more sensitive technique? We don't have a clinical trial answer, but what is your hunch?
My gut feeling, yes, I would sort of. So my thought is like.
So the question is, you're choosing better. So your oligometastatic or low volume will really have a better prognosis. So that 8 years might actually become 10 years, 12 years now. And that poor prognosis might actually be even shorter because you're going to choose that set of patients even better because you're going to pick up more.
In some ways, the answer is yes.
Okay.
But it's such a, till you don't have that data to prove it, it becomes very difficult.
I agree. We don't have the data to prove it.
So the thought comes from the M0 space, How many M0s are really M0s? That's the whole issue. And if that PET answer was there in the M0 space, we would have definitely been able to answer better. Those who were PET positive in M0, how did they fare versus those who were PET negative in M0, how did they fare? That would have answered this.
Absolutely. So there is a retrospective study done on that, Amit, which clearly showed that the non-metastatic castrate-resistant group, when they did a PET, they've only found that 10% of patients who actually they thought were non-metastatic were actually non-metastatic. So that's the point I'm making. You will be able to choose your patients better. Your oligomets are really oligomets, and your poor prognosis is really poor prognosis. Then you will call in the molecular biologist, add some tests there, and will be able to choose those patients better. I think our stratification of patients will only get better as we get into the future.
Just a quick word on that. So the way they're talking about oligomets in the future is, you will not only take the number or seeing the PET, you will probably put the PSMA PET uptake into it, the value of the uptake.
Very good. So many things will come into that variable. Excellent. So please remember that it's still important to do this stratification. The value might be different depending upon how you look at it, but I think there is still some value to it. Let's do this case. It's a very simple case, something that we see every day. This is a de novo, high burden, high risk disease. 60-year-old diabetic, hypertension, LUTS of 3 months, the PSA was 122, performance status is 1, hard nodular prostate, Gleason is group 5, PSMA PET is, what I'm showing you here, multiple bone metastasis, obviously high burden. Any other test that you want to do? Dr. Amlesh, let me start with you. Do you do molecular testing at this point in time?
No, in our practice, we do it at a later stage.
Okay.
Yeah, but yes, as per the literature, at least BRCA is recommended. The detailed genetic testing may or may not be done, but yes, BRCA should be done in this situation, yes.
Excellent. Vinayak, do you do molecular testing right away at the time of diagnosis, or you wait for CRPC?
No, I will do it if they are affording that.
You will do
Nothing
it
to do with the stage.
Okay, excellent. Let's get to our basic scientists here, Dr. Arun and Dr. Mitwa. Dr. Arun, which is better? Do we have concordant studies between blood and tissue? Do you have data on that?
Well, so most of the analysis that has been done comes from the tissue. And when you talk about it, when you talk about the blood, you're talking about things that happen systemically as well. So, you always have to go for the tissue first and then try to extrapolate it from there to the blood. Having said that, one of the things that we need to also understand is we always take snapshots. When you take let's say a genomic test, or if you take a proteomic test or a metabolic test, you're always taking a snapshot, and you're not really looking at the plasticity of the tumor. And because of the plasticity of the tumor keeps changing over a period of time. So I think that should be something that we need to keep in mind as well.
Okay, so you're saying that you will be able to do blood repeatedly and see what's happening. It's a more dynamic way of assessing the tumor biology rather than looking at tissue at one time.
Right. I think anything that is coming from the tumor has to be first taken into consideration and then extrapolated into blood as something that you can monitor over a period of time. But solely going from the blood backward may not be the right thing, because you're also confounding the systemic changes that might be happening in the system, in the individual.
Dr. Mitwa, blood or tissue, and do you have concurrent studies that you have done or you know of?
Yeah, so I would always prefer tissue, and I second Dr. Arun about it. And I would always prefer a comprehensive genomic profiling.
Okay, you've already come to that point.
Yeah.
Okay, can you tell us what that comprehensive genomic profiling is and what would you like to look at?
Yeah, so basically, see, there are a number of markers or biomarkers, and what Dr. Amit pointed out, if you really want to stratify and subtype these tumors, you need to have a comprehensive profiling where you have, specifically in our data, we have seen AR pathway is something which is altered in 50% of Indian prostate cancers, which I have not seen in African patients, surprisingly. And AR mutations and all are, I think AR mutation or amplification or spliced variant are very important genetic alterations which might give resistance to abiraterone or enzalutamide or whatever you're using. And all your clinical trials are not using those enriched markers to stratify patients. So I think it's the need of the day we should do this. And I prefer to do it at early diagnosis and not at later stage.
Very good. So that's a very important one. So for beginners in molecular biology, we are all beginners in our own ways, but for the true beginners, there are two things that you can use for testing. One is you can use the circulating tumor DNA or the plasma. The other thing is that you can use tissue. Now, whenever you look at most of these testing algorithms, it will tell you that you do the tissue first and then you go and do the blood, which is typically what most of us do now. The reason for doing tissue first rather than doing blood first is that you tend to pick up more somatic alterations which may or may not be reflected in the blood. So these HRR mutations that we are talking about, which have both prognostic and predictive value, that means if you have a HRR mutation, you're likely to respond to a PARP inhibitor. That's something that you have a greater likelihood of picking up on the tissue rather than in the blood. The importance of doing blood is that these germline mutations, that means things which are inherited from generations, are likely to be picked up better in the blood. And that's how you also confirm the presence of a germline mutation that you picked up on a tissue. So that's why you do the blood. Now when, yeah, Dr. Makaran, please.
Yeah, just a quick point here.
Yeah, please.
I think I would sort of have a comment as a clinician.
Yes, please.
As when the patients ask for investigations, now you see the prostate cancer diagnosis, right from diagnosis, it will become an expensive affair now. You do the MRI first, then we do the PSMA PET scan, we do the biopsies. Before we reach a diagnosis of these kind of patients, usually patients would have spent at least 1.5 lakhs in terms of diagnosis, MRI, PET scan. Now the thing is that we want to know whether this molecular testing at this juncture, is it going to add any benefit in terms of treatment? Because his whole life now is all going to be cost consideration, number one. And none of the guidelines suggest that when you have an obvious metastatic disease, these molecular markers would add any benefit. If you look at all the guidelines, they would say the recommendation is not very strong. Yes, it's useful. When you have family history, you want to active surveillance in these kind of patients, certainly we will do.
Okay, very nice points. Now,
Dr. Senthil,
yeah.
Going ahead with exactly the same question.
Okay.
I would like to ask Dr. Mithun that in the Indian patients, in your lab, you have found that more than 50% or about 50% of patients have androgen receptor variations, etc. So would that translate into a change in the ADT management, or would that translate into change in abiraterone therapy or enza therapy, or is it mainly for telling the patient that this is the thing and what the future is likely to be? That's the
Yeah.
Dr. Mitwa, he is asking you that question. So is it going to impact your treatment? Is the question. So if you, let's say you find some mutation in the androgen receptor pathway related genes, are you going to tell your clinician this guy is going to be resistant, so don't use it, and will he not use it, or will he use
definitely.
it? So that's the question.
I'm going to,
You're going to warn your physician.
I quickly pick up the call and inform the physician, and it's definitely physician's decision to change or not change. But see, the main important thing is you can have a combination therapy. Rather than giving just abiraterone or enzalutamide, if you have such type of resistance, maybe you cannot deprive your patients of those therapy, but you can have a combination therapy there. That's what I understand.
Okay, Dr. Arun, quick comment and then we move on. I don't know. It says 9 minutes.
I'll just add one thing
panel?
about, when you have androgen receptor variants.
So we have cut down the time to 20 minutes?
This is again coming from basic research, which is basically getting translated to some extent. We see that these patients become more addictive to fatty acid metabolism, for example, because when you have an ARV7, it drives fatty acid metabolism. So, there could be additional agents that could be brought in. For example, fatty acid inhibitors, which are out there, like TVB2640, which could be brought in as an additive in addition to just the conventional anti-androgen treatment. So the point is, when you do this molecular testing, you also look at dependencies of the tumor on certain metabolic pathways, for example, the things that we do, and we do see some interesting caveats.
Okay, so excellent point. So any test that you do from a therapeutic standpoint, at least, please tell your patient that this will help, this will not help, and this will just be prognostic, this will be predictive of what I'm going to do and not to do. That's very important. Cost is an important point that you will have to consider before doing any test. That includes a PSMA PET CT scan, right? Do molecular testing at some point in time, especially if your patient can afford a PARP inhibitor, because if you can't afford a PARP inhibitor, there's no point in doing that molecular testing. Germline testing is relevant irrespective of whether you can do a PARP inhibitor or not, because that's about 8 to 12%. It seems to be a little less in our population. I don't know why. Maybe if you test more, you will pick up more, because that's very relevant for the family, not necessarily from only a treatment standpoint. So genetic testing, molecular testing has got various implications. We understand a little bit of it now, but as we go by, our understanding will improve, and you will start incorporating this in various kinds of decisions that you make during the course of your patient's treatment. So get sensitized to the fact that we need to test. I think we'll leave it at that point.
Okay, Senthil,
so
just
quick,
one
quick
sentence.
comment. Yes, please, quick comment.
The lack of response in the clinical setting to any of these hormonal agents is less than 10%. I mean, most of the patients, more than 90% of the patients will respond to hormonal therapy. So, and even if the genetic testing is showing about 50% response, I think there is some kind of a disparity between...
You're absolutely correct. So the point is that, ARV7 was marketed as a big test at some point in time. We know that at the time of diagnosis, less than 10% of patients, as was rightly pointed out, will have some alteration that makes you resistant to ADT. But what Dr. Mitwa is trying to say that, we've started doing this in many other malignancies. So it's not new for, medical oncologists. Maybe it's a relatively new one for urologists, especially the beginners. So we've started looking at many other genes which, predict for resistance to therapies. And what we do is not change therapy. I think it's very important to keep a closer watch on your patients, because suddenly, they just blast off with treatment, disease all over the place, and you lose your chance to do a second line treatment. So that's the relevance, at least at this point in time. It's not going to change treatment, but you can tell your patient, look, I'm using this, but don't think you will get the chartered or this, latitude result that they're showing of a survival of, 6 years or 5 years or whatever it is. You're likely to do poorly compared to what another patient who's not carrying these alterations. I think that's the point that we are trying to make, not that everybody should get all these tests done. Vinayak, de novo high burden disease, 60-year-old, nothing much in terms of comorbidities, triplet, doublet, Vinayak? Triplet therapy. Let's quickly move on. Darolutamide or abiraterone?
Abiraterone.
Abiraterone, why abiraterone?
Once we get the other drug, I may think about it.
Pardon me, I can't hear you. Mic closer to you.
Easy to
Mic
do.
closer, mic closer.
Personal choice.
It's a personal choice? Okay. Amit, darolutamide, abiraterone.
So abiraterone has worked well in our practice, and I don't think really we are switching over or thinking about that. We've heard about darolutamide being less toxic, especially less CNS side effects, and that's the reason a lot of darolutamide is being talked about. But again, the drug is not, it's just started becoming accessible in India, and it's very expensive. So cost-wise, abiraterone works very well.
Excellent. So cost-wise, abiraterone looks good. There's no cross-comparison of data. but it looks like darolutamide might be a little less toxic. When you cross-compare, the hazard ratios seem to be more in favor of darolutamide rather than abiraterone, but this is purely cross-comparison, so let's not get into that intricacy. How do you manage patients with stage 4 or non-regional lymph node metastasis? Because I recently saw a very learned doctor in a 60-year-old asking for docetaxel plus ADT in patients with lymph nodal metastasis as the reason for M1 or M1A. Is this low volume? Is this high volume? Is this low burden, high burden? This is a constant confusion that many people have. I thought we'll clear that confusion here because that is stage 4. Lymph nodes all over the place. You know, the bulkiest one being 5 centimeter retroperitoneal. Dr. Makaran, you've got the mic so you can answer.
Yeah. To my mind, I think bulky lymph node disease is usually a challenging situation because I slightly disagree with the comment which you just made that the bony metastases do badly as compared to the lymph nodes. But I think if you have extensive lymphadenopathy, what you said, in my opinion, they do very, very badly.
Okay.
So in that, I think go all out to the kill as much as you can.
Okay. Triplet.
That will be the...
Let's say triplet?
Yeah.
Okay,
yeah,
good. Excellent. Okay, but let's say the run-of-the-mill lymph nodes which are 2 centimeters, what would you do then?
Sorry?
The usual lymph nodal metastasis, the 2 centimeter ones that you see all over the place, 1 centimeter supraclavicular, is that a place where you would be very aggressive?
Yeah, I think the counseling, I mean, just ask the patient, we are going to offer this, what is going to get involved, or otherwise you go for a standard of care plus AB.
Excellent,
A
okay.
small point here I'd like to make,
Dr.
and I would like to draw attention, and I think we all can as a community get into it. We have this Australia Asian Prostate Cancer Group.
Yes.
We look at the real life scenario, and we are now working on a low dose abiraterone without any steroid with a fatty food. I'm sure there is enough.
Yeah, we're
amount of
already doing
evidence.
it, isn't it?
So if we can incorporate that also something good, just a 500 milligram without any steroids with a fatty food.
It's already in the NCCN guideline, especially in the CRPC setting. 250 milligram after food is already there. So the reason why I brought up this point is by the Stampede criteria, lymph nodal metastasis is low volume disease. Okay, it is not high volume disease. So your intensification has to be in line with what you would have done for a low volume disease. You won't do triplet therapy straight away. Docetaxel is not the drug of choice in a situation like that. There may be exceptions like what Dr. Makaran said, you've got bulky lymph node, let's say a 10 centimeter lymph node, which is not very common, but once in a while you see a patient like that, your decision might be a little different. But typically lymph nodal metastasis is classified low volume. You will approach it like low volume disease. Amit, anybody gets docetaxel and ADT in your practice? I asked this to Ravi. In my practice, it's nearly zero now, so I want you to...
I kind of agree, fully, because whoever gets docetaxel eventually gets hormonal, so now the only thing is we have data about going together, so we know it's safe to do it together, so now it's become triplet much more. My only contention to a triplet is, I wish there was a hormonal arm comparison, We don't know whether dosi is adding value or not.
Great, quick point. We've got 1 minute, 27 seconds.
Immunohistochemistry, because it will definitely going to give an opportunity to identify a neuroendocrine, and that will entirely going
PSA
to change the treatment.
Point well taken. PSA 122 Gleason 5, is that an indication? I mean, is that likely to throw up neuroendocrine? More likely, all are PSMA avid. There's no area in the PET scan that's not PSMA avid.
So 5+5, we tend to do it. We tend to do of the IHC.
Likelihood of picking up a neuroendocrine component that will change your therapy? 5%, 10%, 50%?
So sometimes, so these are patients who will definitely get chemotherapy.
So essentially, point well taken. It's good to do an immunohistochemistry, but in the setting, the likelihood that you will find a neuroendocrine component, though is there, is very small. If you do neuroendocrine component IHC on 100, please, sorry, I don't have any more time. If you do it on 100 patients, you will always find that there is the patient who will have a speck of it, but that does not change our therapy. It's going to change your prognosis, but it's not going to change therapy. We've got a nuclear medicine physician and a radiation oncologist here. So I want both of them to quickly say, the radiation oncologist, when would you radiate the prostate? One. For the nuclear medicine specialist, when is it that you will come in to do lutetium PSMA? So I want to do that before we stop. Unfortunately, my panel was 42 minutes. It's been cut down to 20 minutes. So 32 minutes cut down to 20 minutes. So I will, take the liberty of using 2 minutes.
Yeah, I think with the disease, what you showed in a PSMA scan, this one, once they fail all these treatment, this is the way to go for lutetium.
So when would you say a patient is appropriate to be taken up for lutetium PSMA therapy?
At this point in time, it is the last option.
Oh,
but,
you say, okay. I just wanted to summarize by saying it should not be the last option.
It should not, that's what I was coming to. It shouldn't be the last option. But I think after the vision and the therapy trial came into picture, the practice has changed slightly bit. And PSMA therapy has jumped 1 or 2 spaces.
Yes.
We are doing now in more earlier cases, and probably cabazitaxel will gradually fade away. That's what.
Okay, fade to the next line rather than saying fade away. We'll need as many therapies as possible. Dr. Makarand rightly raised that point, asking what will you do on a rainy day. Just Dr. Makarand, if you look at the data, and I put that up here, 80% of patients actually got an NNA later. Those who were on the placebo arm. But in spite of 80% of patients getting an NNA later, still the triplet had better overall survival. So I think we will not wait for the rainy day. We'll push everything up front. And prostate cancer is one area where intensification has, consistently been beneficial in overall survival. The radiation oncologist, I'm so sorry I have to cut off, and we don't have a lot of time.
So to be very crisp for this case, absolutely no role of radiotherapy.
Excellent. When would you want to
Yes, where would we intervene? Again, the definition for the number of the low risk is still a bit of a debate. Internationally also, we haven't yet arrived at a set, number. But according to the data we have, there's a latest paper in JAMA which came out from the UK group, and they've shown that 3 or less than 3 bone metastases, there is a definite overall survival benefit when you irradiate the prostate, and there's a difference of about 10%. I think standard of care plus RT is 85, the 3-year curves were 85% versus 75% for standard of care alone.
Great, thanks. So let's summarize. Any other points that anybody? Yes, Dr. Makaran.
Just wanted to say, suppose he responds extremely well. At the end of 6 months, everything is gone, his PSA is absolutely 0. What you see in a PSMA PET scan is just the only disease in the prostate. At this point, would you do radiation to the prostate?
The baseline status of the patient doesn't change. At the end of the day, he is a high risk, high volume patient. So I would not irradiate this patient even after response to therapy.
Absolutely. So we would probably be treating the scan rather than treating the patient or the biology. I think that's very important to keep in mind that you treat the biology very importantly. So summarizing, categorize patients at diagnosis. I clearly agree with Amit that the borders are getting blurred. But there's still a border. With new therapies coming in, you will have to reclassify and treat patients. It's got very strong prognostic value. The predictive value probably has gone down a little bit from when it all started. I think triplet is the standard of care. There isn't too much of debate about it because the adverse event profile, as Ravi clearly showed, is not very different. Discontinuation rate. You will be surprised to know that the placebo arm, 10% discontinued placebo. 13% discontinued darolutamide. So it's not very different. It's not very toxic. It's very manageable. We already started doing it in practice. So for de novo, high burden, and I'm repeating that, it's de novo, high burden, HSPC, triplet seems to be the way to go. HRR testing in the appropriate setting, that's standard of care now. So you could do it at the time of diagnosis. You could do it at CRPC. There are some technical issues. We didn't have the time to go into it. But do it at some time if your patient can afford PARP inhibitors. If your patient can't afford PARP inhibitors, please don't do it and then, cut a sorry figure in front of your patient saying, you can use this therapy, but I can't do it though. Judiciously use the PARP inhibitor in CRPC is not as simple as every HRR mutation will respond well to this therapy. Some mutations have better response compared to the others. Pharmaceutical companies have been extremely smart the way they have published their results, the way they have combined all these HRR mutations into one group and telling us that everybody benefits. I, for one, I certainly do not believe that all of these mutations are one and the same. Like Dr. Mitwa and Dr. Arun clearly pointed out, the future will be to test more, understand the biology better, and treat your patients better because they are not the same diseases at the end of the day. We will certainly do radiation to the prostate, at least at this point in time, based on the available data for low volume disease. So again, that's an area where you will need to classify. please do not keep PRRT lutetium for the last, right? No therapy works at the end, please remember this. You should not do everything when the patient's got performance status 3 or 4 and then say it didn't work. The importance of doing all these tests upfront is that you have a roadmap laid out for your patient, as Dr. Makarand rightly said. And if you're laying a roadmap, if there are no major hassles or hurdles in between, you will follow that roadmap and clearly say, I want to do PRRT, and this PRRT has moved before cabazitaxel now. Because the responses, I think the endpoints were not nicely done in the vision study, the first one that came in ASCO 2 years ago. I think they were not very confident about achieving the endpoint, so they went for 50% PSA response as the endpoint, which is not an accepted surrogate. Otherwise, you would have moved a couple of years ago ahead of cabazitaxel. But yes, he is absolutely right. Dr. Chowdhury is right that you place it before cabazitaxel. Cabazitaxel comes after that now in your algorithm for treatment of prostate cancer. I'm so sorry, Dr. Vineet, for taking a couple of minutes, but I hope I made a few things clear for the audience so that we don't get confused at the end of this.
Can I add one point, Dr. Senthil, just to...
One point?
Yeah.
Okay, since the lady is asking, I can't say no.
So whether you do a genetic testing or not, whether you do it at early stage or at a recurrent stage, but my request to all clinicians and my suggestions also, please refer your patients to at least genetic counselors, because they are the person who actually identify the patients at risk which you might have missed.
That's another Pandora's box.
Yeah, and that helps a lot, and we will always take clinicians' consent to do any test in future.
Thanks so much for making that point, madam. Thank you so much, all of you.
Yes, sir.
That was a wonderful session. So let's move on to part 2 of part 1 of the day. We move on to a neighboring organ, the bladder. The next session is on locally advanced and metastatic bladder cancer. Can I call upon the chairpersons for this next session? The chairpersons for the next session are Dr. Ganesh Gopalakrishnan, Dr. Vineet Talwar, and Dr. M. Belliappa. I request the chairpersons to take their place on the stage and also to call the first speaker. Thank you.
Hello, check.
Good morning. Welcome to the second part of the session for this morning, and thank you to SOGO for the invitation and the opportunity. I'm given to understand that the first speaker is not there, so could I call upon Gagan Prakash. Recurrence patterns, post-definitive therapies in bladder cancer following radical surgery and radiotherapy. Dr. Gagan Prakash. Anybody knows where Dr. Gagan is? 1 minute. Is Dr. Warrior here? All right, okay.
So I have the privilege of introducing Dr. N.K. Warrior, who's the medical director at the MVR Cancer Center in Calicut. And he'll be talking about the immune therapy related toxicities and their management in urothelial cancers. Over to you, Dr. Warrior.
Yeah, thank you, Dr. Vineet, and the organizers for this invitation. Immunotherapy marks a new era in the treatment of urothelial genitourinary cancers. There are 3 immune checkpoint inhibitors targeting PD-1, PD-L1 or cytotoxic T lymphocyte antigen. You can expect more number of checkpoint inhibitors waiting for their approval for the future use. So basic minimum knowledge of the toxicity of these immunotherapeutic agent is essential across all specialties, as genitourinary malignancies are the typical example of multidisciplinary management. The toxicity profile of these immunotherapeutic agents are totally distinct from the traditional cytotoxic chemotherapy, and they can occur. You can expect the toxicities at any point of time in the management of in the treatment with the immunotherapeutic agent, as well as even sometimes you can get these toxicities even after stopping the treatment. So these are the key pivotal studies on metastatic urothelial cancers and metastatic renal cell carcinoma, which led to the approval of 5 important immunotherapeutic agents. They are nivolumab, ipilimumab, avelumab, pembrolizumab, and atezolizumab. And if you look at the indications, the current indications based on the data from the pivotal trials, the current indications are for the upfront use of metastatic renal cell carcinoma as first line, and as a second line management of metastatic urothelial carcinoma, and the maintenance after first line platinum based chemo, and also those who are not eligible to receive the platinum therapy can also be treated with immunotherapeutic agents. The immunotherapeutic agents have proven efficacy in the rare neoplasms like adrenocortical carcinomas and the germ cell tumors, penile carcinomas. These rare neoplasms, though they have shown improvement, but yet to get the approval. One interesting point is that the immunotherapeutic agents, though they have studied extensively in the management of metastatic prostate cancer, but yet to get approval. As they have failed to show any improvement either in the DFS or in the OS benefit. These are the common toxicities one can expect when using immunotherapeutic agents, right from almost all the organs can be affected with these toxicities. The common manifestations are dermatological and as well as the endocrine abnormalities. But there are more serious adverse events like the involvement of central nervous system and cardiovascular system and hematological abnormalities. These three are probably the central nervous system, the cardiological and hematological toxicities are very dreaded and sometimes even life-threatening. Some of the very common toxicities are like the dermatological, like rash, pruritus, and the vitiligo-like reactions. And the endocrine abnormalities, almost all patients will be having some kind of endocrine abnormalities like thyroid dysfunctions and sometimes severe endocrine abnormalities like hypophysitis and adrenal insufficiency can occur, and unless you are familiar with these side effects if you are vigilant, then only you can pick up these abnormalities in your clinical practice. Typically, the serious adverse events are myocarditis. The dreaded complication is myocarditis, pneumonitis, and as well as hemolytic anemias. And sometimes in the eye they can manifest as uveitis and retinitis. The common toxicities generally appear after 4 weeks of immunotherapeutic therapy, and anytime, as I said earlier, anytime they can appear, but generally they appear between 4th week and 10th week. More serious complications like hepatotoxicities and hypophysitis occur between 8 and 10 weeks. So these are the important trials in which these toxicities are recorded. You can see that the percentage of This toxicity varies from 15% to 90%, and vast majority of them are grade 1 and 2, and the discontinuation rate is relatively low, less than 20% in these studies. And these are the grade 3 immune related adverse events are basically, as I said earlier, myositis, myasthenia type of syndrome, and the CNS manifestations. It's very interesting to note that between the agents the toxicity varies, and ipilimumab, the typical the CTLA4 inhibitor, has got is more toxic compared to the conventional immunotherapeutic checkpoint inhibitors. And when you combine these, like the nivolumab and immunotherapeutic agents, the toxicity percentage, the incidence goes up to 40%. When used alone, it may be less than 10%, but when you are combining them, the toxicity goes to 10%. It's about 40%. These are the biochemical mechanisms. I'm not going to the details. And when coming to the management, the prevention is always better, and anticipate more adverse events related to the immunotherapy in patients who are having pre-existing autoimmune disease like the collagen vascular disease or myasthenia gravis, or those who have undergone organ transplant. So these patients are probably a relative contraindication for starting immunotherapy. And anticipate, you can expect the basic these toxicities. So one has to be very careful and doing baseline checkup and on follow-up, as well as during the treatment with the more frequent investigations, and looking for specifically for these toxicities. And once they develop adequate treatment with the corticosteroid is the key. So before starting the treatment, one can go for all these investigations, like the baseline investigations, the electrolytes, as well as the hormonal assays, and also the doing a virology screen is good, and antibody is like a NA profile and TPO antibody and the thyroglobulin antibody are all indicators of having more toxicity, or one can expect more toxicity in such situations. Are there any predictive markers for identifying this immunotherapy related adverse events? Yes, there are many, but none of them have proven its merit in its clinical use. So these almost all the professional bodies have graded these toxicities. So knowing these toxicities and approaching the management of toxicities based on this grading system is very helpful, very useful in the management of these toxicities. So the different grades are like the mild, grade 1, and grade 2 is moderate, grade 3 is severe, and grade 4 is very life-threatening situation. You can see that the grade 1, that mild and moderate, probably needn't go for the discontinuation, but only to the prompt starting of corticosteroids. And the life-threatening situations, you may have to use higher dose of steroids. So immunosuppressive agents, the corticosteroid plus or minus mycophenolate is the key in the management of managing these toxicities. And whenever the patients are not responding within 72 hours, look for other causes as well. So summing up, the immunotherapy is better tolerated than chemotherapy, but it is not without any side effects. Can have adverse events that patient have not had with chemotherapy, and toxicities are same as in other sites. Urothelial malice are not an exception, but most of them are reversible by a prompt use of steroids. Thank you for your question listening.
Thank you very much, Dr. Warrior. Could I ask you a question, please?
Yeah.
In your practice, how many of the patients with bladder cancer who come to the stage of ICIs are you able to actually administer that drug?
Pardon?
In your practice, how many patients with bladder tumors who come to the point where they require immune checkpoint, what's the percentage, a ballpark figure?
Yeah, at the moment it's less than 10%.
Less than 5?
10%.
Is it because of the cost, or is it because of the fact that the disease itself.
Multifactorial, like the approval was, the data was not much for the upfront usage in metastatic urothelial malignancies, but sometimes when they are ineligible to receive cisplatin, we will advise them to go for immunotherapy. And now the metastatic renal cell carcinomas, majority of them will be offered this, but because of the cost involved, only 10% will be going for that.
Thank you. Is there any other question? One question, please. Thank you very much, Dr. Warrior.
Thank you.
We'll move on to Dr. Gagan Prakash, please. He is at the TMH in Mumbai. He's going to talk to us about recurrence patterns, post-definitive therapies and bladder cancer following both radical surgery and radiotherapy. Over to you, Gagan.
Thank you, sir. Good morning, everybody. Thank you for this invitation. I would be talking on recurrence pattern post-definitive therapies, that's after radical cystectomy and trimodal therapy. Greetings from Tata Memorial Hospital and our expanding centers across the country. Incidentally, the two large series on this topic are from TMH, and I'm happy to discuss our findings here. And I will try my best to wear an oncologist's hat rather than a surgeon's. We essentially would be using these two terms across the slides. So in the next 10 minutes, we would see how commonly do these patients recur after these therapies, where do they recur, and does this differ after cystectomy and trimodality therapy? What are the implications for surveillance strategies? Can these recurrences be predicted? And can these recurrences be prevented by some kind of a treatment intensification? What are the options of salvage once the recurrence has happened? And some specific issues relevant for surgeons. Let us start with a glimpse of our unpublished series comparing the recurrence after surgery and bladder preservation in the same time period. These are from 146 bladder preservations and 230 cystectomies. These patients are not matched for stage, and in general the cystectomy patients were of higher stage. Over a median follow-up of close to 3 years, around 34% of patients post-trimodality therapy recurred, but these were including 16 patients from non-muscle invasive bladder cancer as well, and 27% patients post-cystectomy. If you exclude the ones who had non-muscle invasive recurrences, then the recurrences were lesser in the trimodality therapy. One second, there's a slide. Yeah. So this study intended to highlight not just the patterns of recurrence post-cystectomy, but also the fact that in a predictable subset of patients, there is a higher incidence of locoregional recurrences, and possibly these subset of patients might benefit from adjuvant therapy. So we need to have a standardized definition of defining these recurrence sites, and that attempt was made in this study. So essentially local failure is something which happens in the cystectomy bed. Regional failure is in the lymph nodal areas, essentially the pelvic lymph nodes up to the aortic bifurcation, including internal iliac obturator, external iliac and common iliacs, pelvic side walls, presacral and the rectosigmoid region. Whereas the distant failure is outside the pelvis. And for the sake of this study, locoregional and distant failures were considered synchronous if they happened within 3 months. So essentially there were 188 eligible patients, and 29% of them had recurrence. Locoregional were in 6% patients, and a mixture of locoregional and distant was 10%. So a total of 16% patients had a locoregional component. Now, we further looked at whether the patients who are most likely to fail locoregionally could be predicted based on various pathological factors, and such attempts have been made in the past as well. By dividing these into various groups, we could identify a high-risk group where the locoregional failure was close to 35%. And this is, how we kind of a little complex system, but essentially considering the T stage, N stage, and the presence or absence of LVI, that the risk stratification could be done. Now, based on this understanding, we have this ongoing study which Dr. Vedang Murthy is leading from TMH, where we are trying to see, it's a randomized trial, we are trying to see if after cystectomy, by addition of radiation therapy in high-risk patients, can the loco-regional relapse-free survival be reduced? So that's the primary endpoint in 153 patients. This particular study from Europe has actually created a nomogram, again looking at various factors which could predict the chances of a loco-regional recurrence. The USC group has now come up with a web-based platform, which is like an application which utilizes all the host, the treatment, the disease, and the patient-related factors to kind of predict where this patient is more likely to fail. And of course, based on our understanding of where they fail and when they fail, the surveillance strategy should be tailored. So a large series, finding that 30% are distant mets, 10% are local pelvic tumor recurrence, and 64% are symptomatic, 34% are diagnosed at a standard follow-up, and 2% are diagnosed coincidentally. And then based on the T stage, the positive lymph nodes, and upper tract dilatation, they were able to dichotomize the patients into those who need a more intense surveillance versus those who could be a more flexible one. Late recurrences, so close to 10% of the patients could recur even after 5 years of follow-up. Let's move on to the scenario which is post-trimodality therapy. So another large series led by Dr. Vedang Murthy, where they looked at the adoptive radiotherapy, essentially trimodality therapy for muscle invasive bladder cancer. There were 106 patients, and almost 76% of them received concurrent chemotherapy as well. At a median follow-up of 26 months, the 3-year loco-regional, disease-free, and overall survival was 74%, 62.9%, and 68%. Now, what I wanted to highlight over here as an understanding is that when we look at patterns of failure post-trimodality therapy, there is a group of patients who would have only a non-muscle invasive bladder cancer, where the bladder can possibly still be preserved and salvaged. And these patients would need a TURBT or a combination of TURBT followed by some form of intravesical therapy. And that's how, another different outcome from cystectomy over here is the bladder preservation rate, which in this series was close to 91% at 3 years. Now, from various other studies, one of the things we know is that the recurrence estimates post-trimodality therapy is close to 25 to 50%. And around 26%, 1/4 of these recurrences are non-muscle invasive, around 16% muscle invasive, regional nodal around 12%, and distant around 32%. What do you do when you have these recurrences post-trimodality therapy? So if it's a non-muscle invasive, then it's TURBT with or without intravesical. If it's muscle invasive, it has to be a salvage cystectomy. And then upper tract recurrences, which happen around 5 to 10% of patients, managed similarly to those occurring otherwise. And distant recurrences has to be systemic therapy. Now, as surgeon, I think most of us have had some experience about salvage cystectomy, post-cystectomy, and this study from the World Journal of Urology was the largest series which I could find. At a median follow-up of close to 61 months, the salvage cystectomy rates were around 19.2%. The overall complication rate, which most of us apprehend, range between 70 to 72%, with a 30-day mortality of close to 8%, 0 to 8%. And the 5-year and 10-year DFS after salvage cystectomy was 54 and 45%. So this study saw that there seems an improvement in outcome and decrease in requirement of salvage cystectomy over decades. This is possibly because the techniques and understanding of bladder preservation has actually evolved over the years. Now let us look at some specific aspects of recurrences post-cystectomy. How common is urethral recurrence? Meta-analysis close to 9,400 patients found a urethral recurrence of 0.8 to 13%, and these happened within the first 3 years. Diversion prior to cystectomy is a common scenario, particularly in Indian patients, where they often present with obstructive uropathy. With DJ stent, the chances of having a urethral recurrence seems to be higher than compared to percutaneous nephrostomy. Some reports about the value of frozen section. If the patients have received NACT, now there's some literature to say that the chances of having a distant failure is reduced, but the chances of having a loco-regional failure does not change after NSCT, and probably again undermines the value of a likely, additional therapy, as in radiation. Quickly about the robotic cystectomy and the patterns of failure, because post-radical cystectomy, there were initial concerns that the patterns of failure are a little unusual and there is disseminated mets, but now there are large series which have kind of, proven that the patterns of recurrence post-robotic cystectomy does not differ from open cystectomy if it's done in high volume centers and with all the precautions. Thank you on behalf of the DMG and particularly Dr. Vedang. Most of the work has been led by him here. Thank you.
Thank you very much, Gagan. Any questions? 2 questions allowed? No questions? Obviously, you made your presentation very clear, Gagan.
Thank you, sir.
Thank you very much. Yes, anybody?
One question too, Gagan.
Yep.
So post radiation, TRBT and BCG, does the bladder sustain that?
Yeah, so some patients it could, but yeah, that's obviously a practical problem. All of us know about it.
Okay.
Yeah,
so
and particularly with the BCG that we are using right now, most of them are not able to.
Not able to sustain. Look, what I wanted to know is whether my observation is the same across the board as well.
Yes, yes.
Thank you. I'm not sure if Dr. Gopayar is online. Could somebody tell us whether he's presenting online or... We'll just go to then Dr. Badrinath Koneti. Is he here?
No, he's online, sir.
He's online? Okay.
So online meaning Zoom? Recorded presentation. It's a recorded presentation, sir.
Right, okay.
Recorded presentation.
It's my pleasure to invite Dr. Badrinath Koneti. I think everybody here in this audience knows.
Apologize for my mistake.
Apologies.
Sir is here.
I was told that he was here, but thank you very much, Badri, for braving the journey, and welcome to SOGO 22. We all know Badri very well. We know his credentials, and I'm not going to waste time on that. So let's hear from him on the role of biomarkers in follow-up and prognostication of bladder cancer. Over to you, Badri. Thank you.
Thank you very much. First of all, I'd like to thank Dr. Raghunath and Dr. Rawal and all the other organizers who I have not yet completely met for the opportunity to come and present. I know my mother also thanks you all because this gives me an opportunity to go say hi to her and make sure she's doing okay post-COVID as well. So thank you again for this opportunity. I thought I'll take this chance to talk a little bit about different types of biomarkers. We'll talk about biomarkers a little bit in non-muscle invasive and also in muscle invasive bladder cancer and how they can help in prognostication. They told me I had to put a bio slide, so I put it up there. So, and I just wanted to make sure that my conflicts were also disclosed with the different companies that I work with. So the reason for having biomarkers, particularly urine-based biomarkers, where most of the work has been done over the last several years, is because we need something that's consistent, black and white in results, helps us with cystoscopy during follow-up and also during workup. It can help arbitrate atypicals. We get an atypical cytology reading. What do we do with that? Can we help assess who is going to respond to intravesical therapy, such as BCG? Can we triage hematuria patients so we don't have to work up everybody? And then can we really reduce cystoscopy in surveillance? This is the toughest one because as urologists, we always rely on looking in the bladder and doing cystoscopy, but maybe there is a way to do this, like use a bladder PSA, if you will, and avoid doing interventions all the time. The problem with cytology, which has been around since 1945, is it's very variable depending on who's reading it. With all due apologies to our pathology colleagues, it has got very low sensitivity, and you have to send it out, and you have a range of results. You can get atypical, you can get positive, you can get negative, so sometimes it's not clear. There have been some interesting studies done to show that markers can actually help. This is one randomized single-blind trial that was done in the Netherlands, which showed that in one group, they actually did the marker study and told the urologist what the result was, and then he did the cystoscopy. And the other group, they just did routine surveillance cystoscopy at predetermined intervals. And what they found was more tumors were detected when you did the marker right before the cystoscopy, probably because the urologist knows there's a positive test, so we should really be able to find something in there. So there is some benefit to doing markers, particularly at the time of the cystoscopy if you're able to get the result to the urologist. Overall, over the last 30 to 40 years, I've been involved in marker studies at least for 20 plus years, and a whole host of markers have come about, and continuously there's progress almost on a monthly basis, and new markers being released. There are protein-based markers, DNA-based markers, RNA-based markers, tissue-based markers, and then now companion diagnostics and multi-gene arrays have also come. We won't go into all of this in the interest of time, but at least I'll talk about the top 4 or 5 categories of markers briefly. This is just a historical note. Many of you know data on NMP22, BTA, and immunocyte. These are historical relevance only. These markers are all FDA approved, but almost nobody uses this anymore. The only value we found in these markers is they were able to come up with a pregnancy test type format for the protein-based markers NMP22 and BTA. That's really helpful to do right before a cystoscopy or even in the absence of cystoscopy. But the marker characteristics are so bad, we cannot really use them anymore. I don't even think you can buy them now. At least immunocyte is completely out of business. This is a newer protein-based marker that has really caught some attention over the last few years. It measures a protein that's important for DNA replication, which is lost as cells get more differentiated. So in cancer cells, there's a lot of MCM5 that can be detected. There's 3 large studies so far, and the marker is very good at identifying muscle-invasive disease, all the way from T2 to T4. It's also very good at identifying CIS, but it's a coin toss for identifying PTA disease. So it really has potentially some value because of its high negative predictive value. If you do this test in the urine and the test is negative, then the patient is unlikely to have aggressive disease. So there is some attractiveness to this marker. FISH is a DNA-based marker. This has been around for a long time, very popular in the United States. About 25% of all bladder cancer patients undergoing surveillance get a marker test, and most of them get a FISH test. And it identifies increased copy numbers of genes, and you see the read as shown in the picture on the right. It looks for 4 markers, loss of 9p21, which is the most common and first occurrence in bladder cancer. When it goes from papilloma to cancer, the first thing that happens is you have 9p21 loss, and then you have more than 2 copies of chromosomes 3, 7, and 17. So it's a good test. Again, it has to be done by a pathologist, and really it actually pays about 3 times as much as cystoscopy in the US. So urologists love this test. You can do the cystoscopy and do a FISH and make quite a bit of money. You can make more money doing these 2 tests than doing a radical prostatectomy. So it's very popular. These are the DNA-based markers that are newer, again, very helpful, good performance characteristics. Bladder EpiCheck is by a company in Israel that has got very good test characteristics. Assure MDX is also a very good test, but it's very expensive. And it's not yet available in the US, so we don't have a lot of experience using this. It tests for DNA methylation and some gene mutations. The problem with these methylation profiling tests is they look at a whole bunch of different genes. It's unclear exactly which are important, which are not. All the studies are very small, so we need larger studies, and most of them have just focused on ruling out patients with hematuria. So you do the test, and if it's negative, you don't need to do cystoscopy sort of thing. Euromonitor is, again, a nice, interesting test that has come out. Very small, 2 very small studies, but really remarkable performance characteristics. Looks for 3 specific gene mutations, TERT, FGFR, and KRAS, all very common in bladder cancer. FGFR3 mutation is probably also one of the first mutations to occur in bladder cancer, so it's very popular. We even have drugs now targeting FGFR mutation, so it has some value. And it's very common. FGFR change is very common in low-grade tumors. Again, this test looks too good to be true. We need to get more data. As you can see, the number of patients it's being tested on is very small. Again, this is just a laundry list of all the DNA-based markers. I won't go through all of them, but you can see there's just a lot of activity in this area. Lots of companies that are investing and coming up with different things. Then there are RNA-based markers. The advantage of RNA-based markers is these are markers, genes that are actually being expressed, so they probably really mean something. The problem with RNA-based markers is the RNA degrades very quickly, so it's very technically difficult to do RNA-based tests as opposed to DNA-based tests. I've got a lot of experience using CX bladder, and expert bladder cancer is the other RNA-based marker that are available. They use different genes that they're analyzing for. Very good performance characteristics. And CX bladder is made by a company out of New Zealand. It not only uses the gene mutation test, but also looks for, adds other variables such as patient's bladder cancer history, age, gender, etc., and comes up with a score. and there's a cutoff which tells you if this patient has bladder cancer or not. They also have another version that tells you if the patient has high-grade bladder cancer or not. So it's very good for two different things, to evaluate hematuria, but to also determine if somebody who you're doing surveillance on has high-risk or high-grade bladder cancer. It performs better than most of the other studies that are, the other tests that are out there that are FDA approved, NMP22, as well as Eurovision FISH. We've used it in adjudicating atypical cytology. So if you get a patient with atypical cytology and you do a CX bladder and the CX bladder is negative, there's a 0% chance that the patient has bladder cancer. So you can avoid unnecessary upper tract studies, cystoscopy, biopsy, all of these things. So it's very helpful for us in that regard. Expert bladder monitor uses a whole bunch of 5 different genes. And again, it's a very useful test, but the performance characteristics are not that great. Just a good backstory to this test. The reason this test was developed because the owner of this company, his mother developed bladder cancer and died from it. So he felt so sad. He said, I'm going to develop a test to identify bladder cancer early. And so that's what led to the formation of this test. It's still not being very commonly used because we're still waiting to find out if we can improve on the performance characteristics of this test. We did a meta-analysis a few years ago, and we found Assure MDX and then CX Bladder to be the 2 best tests compared to all the others available at that time, both in sensitivity and specificity. This is a more recent study from the last year from a European group that looked at 5 different markers, ADX, CX Bladder, EpiCheck, Euromonitor, and Expert. And what they found was all of the newer tests had better sensitivity than cytology, had less specificity than cytology, had better negative predictive value than cytology, and lower positive predictive value than cytology. So there is some value to these new tests, particularly because of the high negative predictive value. So if the tests are negative, you don't need to pursue a workup. And many of the tests can also help identify high-grade tumors or high-risk tumors. So I think there's some value, but we have to see truly how we can apply that. And so there's the first randomized clinical trial that we're part of using markers to see how you can change management of bladder cancer. That's ongoing. So once the study is done, we'll get more data. But if you were to use markers to change how much cystoscopy you do, you can actually use some of these markers to reduce the number of cystoscopies without sacrificing detection of recurrent tumors. So the best 2 tests at this point look to be CX Bladder and Euromonitor, which you can reduce the most number of cystoscopies by missing the fewest number of tumors. So in conclusion, these markers allow more accurate detection of low-grade tumors. They have about a 30% false positive rate. You can help resolve atypical cytology. They can be an early indicator of BCG response. I didn't go into the data, but we and others have published data showing that it can early detect whether somebody's responding to BCG or not, and then you can stop BCG if the patient doesn't seem to be responding. You can reduce the surveillance cysto frequency in some patients, more efficient workup of hematuria, but we still need to better define utility and costs of these markers. The AUA guidelines for microhematuria say you don't need to use any marker, including cytology. They don't endorse use of any of the markers for surveillance or as part of the testing in the workup. But they do endorse use of these markers in arbitrating atypical cytology or equivocal cytology, and also to assess BCG response. A quick word on tissue markers for muscle-invasive bladder cancer. Several groups have analyzed the DNA and RNA mutations and gene expression in bladder cancer tissue derived from radical cystectomy. The UNC group, MD Anderson group, TCGA, which was the national effort, and Lund group in Sweden, as well as one of the companies called Genome DX. And all of them have basically tried to separate out bladder cancer, muscle-invasive bladder cancer, into more luminal-like or into more basal-like, basically arising from the basal cells or from the luminal cells. Luminal tumors in general have a much better prognosis. They're papillary. The cure rate is much higher for these tumors. And one of the thoughts was whether P53 expression could tell us who is going to respond to chemotherapy and who is not. Early studies suggested that maybe there was a difference in response and survival based on P53 expression. A randomized clinical trial was conducted, and P53 was used as a correlative marker, and it did not pan out. So just using P53 does not seem to help us. But if we use the overall gene expression profile, you can actually separate out tumors, muscle-invasive bladder cancers at cystectomy, into different groups. And you can also identify who may respond to neoadjuvant chemotherapy and who won't. And in this one study, it demonstrated that basal-like tumors had the best response to neoadjuvant chemotherapy and got the most benefit in terms of survival. So basal tumors that got neoadjuvant chemotherapy would almost behave like luminal tumors, whereas the other two subtypes of muscle-invasive bladder cancer, there was no benefit of giving them chemotherapy. There is some evidence that luminal infiltrative subtype of muscle-invasive bladder cancer may respond to immunotherapy. So using this type of tissue-based analysis may help us determine who we should give chemotherapy to before cystectomy, who we need to give maybe immunotherapy to before cystectomy. There's some good data now suggesting that's helpful. And we have a trial that we conducted which showed combination of chemoimmunotherapy before cystectomy, maybe even more powerful. So it looks like you cannot really tell who is going to, which of these analyses is the best one just yet. We still need some more data to confirm whether we can use some of this marker profiling to determine how to treat these patients. But I think there's potentially a lot of progress forthcoming that'll help us. Thank you again. Sorry for going over.
Thank you very much, Badri. We know of your interest in bladder cancer, and we look forward to hearing you again in the plenary session. So I think since we are sort of beating the clock here, you want to...
Yeah, as a medical oncologist, in the metastatic setting, FGFR is now a standard. Whenever we check in the second line, we do FGFR, and accordingly, if at this point of time it is not available in India, the drug, but now it is more or less a standard. So I think slowly we are going towards the molecular classification, like in other organs like stomach and lung and breast, so that we can fine tune and reduce the toxicity. So any consensus as of now, are we going really towards the molecular classification, or still we are few years behind?
For muscle-invasive bladder cancer, I think we are. I mean, I use it on every one of my patients before we do cystectomy. And I think some of the people who do a lot of bladder cancer in the US are routinely, we're all doing part of the same studies. And most of us are using Decipher, but there are also several other groups. Sloan Kettering has its own set of markers. That is a challenge. Everybody has their own customized marker set. So which one to use is
so for all patients who are going for neoadjuvant chemotherapy, you are doing this panel?
Yep. What we will do is, if somebody has got other reasons that they may not be an ideal candidate, but if the molecular classification justifies it, we will push them towards neoadjuvant chemotherapy.
Thank you so much, sir. So now we have the panel discussion, which is next, and I've been told that Dr. Kashyapi would not be the moderator. Instead, Dr. Ganesh Bakshi will be holding the fort. So, Dr. Ganesh, I would request you to please call upon your panelists.
Thank you.
And may I request the chairs from the organizing team for the panelists? No chairs?
So my panelists, I don't mind you showing them. Dr. Ananya Chaudhary, radiation oncologist from Bradford. Dr. Hemang Bakshi, urologic cancer surgeon at HCG, Gujarat. Dr. Amit Joshi, medical oncologist at Tata Memorial Hospital. Dr. Prashant Kumar, molecular biologist and geneticist, Karkinos Healthcare, Bangalore. Rakesh Sharma, uro-onco surgeon at Indo-American, Hyderabad. Shayan Paul, radiation oncologist, Apollo. Dr. Shayan. Dr. Ashwin Tamankar, uro-oncologist at Apollo Navi Mumbai. Computer. So this is a panel about locally advanced and metastatic, or rather advanced bladder cancer. Welcome panelists, I hope you have enough place. So let's try to cover up most of the things. Dr. Kashyapi, who could not attend this conference due to some reasons, I am just covering up for him. Most of the work is done by him here. This is our first case. 47 years, male smoker, hematuria since 3 months, and sonography showing 4 by 3 centimeters left bladder wall mass. That's the CT scan picture. So going ahead with the CT pictures, cystoscopy, large solid kind of necrotic mass, left lateral bladder wall, right orifice normal, left orifice seen very close to the mass, slightly restricted mobility. EUA many times people don't do nowadays. Rakesh, would you go for a TURBT, TUR biopsy in such a case?
We go for a TURBT, sir, maximal resection.
Okay.
Try to get the muscle and then take on from there onwards.
Okay, no problem. So, high-grade urothelial carcinoma, lamina propria involved, whoever has done the TURBT, muscle not identified. There are a lot of other things to that. I think it will come in the next bladder panel. So, a short question to Ashwin. Are we satisfied with the report? And then to Dr. Prashant.
Yeah. No,
Any
sir.
molecular subtyping required? Ashwin, you answer both the questions, then we'll go to Prashant.
So I think I'm not satisfied. I'll probably would want to go in again with a TURBT for proving the muscle invasion.
Okay,
Though
just
there-
a short question. On basis of those imaging,
it looks
extravasical.
Extravasical, but I will
Clearly.
still want to prove it for a 47-year-old gentleman.
Patient will curse you.
And molecular molecular subtyping wise, I think it is mandate. It's a necessity, but though we have limitations in India, I would say.
We currently are not following. Prashant, any views on that? Yeah. This is the INCEPT diagnosis.
No, I do agree.
I think they need a mic on the stage.
Yeah, I think the other one.
Yeah, it's there.
Hello, can you hear me?
Button.
Hello.
Yeah.
Yeah. So I completely agree that there's a limitation to the molecular subtyping, and even though you subtype the molecularly, you may not identify something exclusively for the patient for the therapeutics arm.
Okay. So, Prashant, we could not hear you properly, but you said it would be advisable, but not currently probably being followed so much.
Exactly. Yes.
So, will it impact the change we manage bladder cancer right now?
I do not believe. I don't
Amit,
think so.
your quick take on that, because you are.
So at this point of time, it's will not going to change the management, at least at this point of time.
Okay. So roughly, these are very few theory slides in this kind of panel. We have luminal and basal markers, and most commonly FGFR3, and on the other side, we would have MIB, RB, P53 and other PDL1 markers. So, Rakesh, what will you do?
This looks like a minimum T3V disease. We'll stage the patient. No, definitely rebiopsy for muscle invasion. We do it routinely, sir, as a standard. But it looks T3B to me, minimum.
Ashwin, take on it.
So it looks muscle invasive, so he'll be discussed about neoadjuvant chemotherapy. I'll hand it over to the.
So we'll refer to Dr. Amit Joshi here. So Ashwin, you would favor let's come to Amit only. Amit, the questions are right in front of you. Chemotherapy, immunotherapy, how would you choose? Benefits of neoadjuvant, roughly could you tell this multidisciplinary crowd?
So I think at this point of time, definitely first we have to stage the disease. If it is assuming to be a non-metastatic disease, at this point of time, there is no role of immunotherapy. So first we will assess the fitness for chemotherapy, whether his age was 45 or something. So I think that he seems to be, will do some other workup, see the creatinine and the creatinine clearance, another workup, seems to be fit for cisplatin. Then I would like to go ahead with the dose-dense MVAG in this patient. Immunotherapy at this point of time, there are only phase 2 data where the combination of a chemo plus immuno has improved the pathological response rate, but still we have to wait for the phase 3 data before incorporating into the practice. In whom you would not use the neoadjuvant. So in a patient where the creatinine clearance we take is around 50. So if it is more than 60, otherwise fit, no cardiac problem, as such fit, we give the go with the cisplatin based therapy. Between creatinine clearance 50 to 60, we assess individually the patient and then decide for the neoadjuvant. regarding the benefit of the neoadjuvant chemotherapy, so if you go by the data of the meta-analysis for this neoadjuvant chemotherapy, there is around 5 to 6% absolute survival benefit in this scenario. Regarding the side effect and complication, definitely. So that is the thing we have to be careful regarding the selection of proper candidate for this cisplatin-based chemotherapy. Currently, I told you if the patient is fit, the DD-MVAC, dose-dense MVAC, every 14 days will be the first choice of therapy with primary G-CSF prophylaxis.
Okay, so some of the takes from what Amit said is neoadjuvant would give some benefit. Dose-dense MVAC would be better rather than the commonly used GC. It has a Vesper study to that saying that dose-dense MVAC is better than GC. It's proved. And complications might be seen, the medical oncologist might have to look after it. Delay in cystectomy. Dr. Hemang Bakshi, quick comments on two things. Use of neoadjuvant in your practice and usually people complete neoadjuvant. Do you think there is a delay in cystectomy?
Yeah, there would be, but so I would select the patients. Most of the patients would get a neoadjuvant therapy in my practice because that is level 1 evidence, that is standard which we all follow.
Right.
But I would make some exceptions in some patients like massive hematuria,
Right.
recurrent clot retentions, large bulky tumors. There I would go ahead with cystectomy straight. Secondly, cisplatin ineligible with a high
Right, what Dr. Amit said.
Yeah.
Ashwin, quick comment.
Median delay was about 50 odd days in both Vesper trial on both sides, dose day MVAC and GC.
Okay, so Dr. Amit has already answered this question, what was supposed to be cisplatin ineligibility, and the non-eligible patients are with the creatinine clearance mainly below 50 in a grade. This is what is it, cisplatin ineligibility, creatinine clearance less than 50, and other peripheral neuropathies, maybe solitary kidney. Dr. Hemang Bakshi, you have a cisplatin ineligible patient in a MDT. What is the normal decision of your MDT about such patients with such a picture at 47 years of age?
So cisplatin ineligible, if normal would be to proceed with surgery upfront and then take it from there. I mean,
so as Dr. Hemang Bakshi says, we do that. I mean, sometimes we have used these strategies to mitigate nephrotoxicity. I don't know how always successfully they'll work. We'll take comments of Amit Joshi because these keep on happening. So decompression of the obstruction, which is commonly by a percutaneous nephrostomy, nephrology consult, aggressive hydration, dose reduction. Amit, quick comment on these things because we have done these things at Tata Memorial Hospital.
So I think theoretically there is a possibility that we put the PCN and then start the chemotherapy. But in my personal experience, as we have seen multiple times giving this sort of chemotherapy with PCN tube, it's a nightmare. So it's very, very difficult to, most of the time, patient might get neutropenia, might get an infection. And again, this vicious cycle of treating of infection rather than treating the disease. So personally, if the patient is otherwise very fit and the creatinine is not very, very high, we can consider in a selected patient putting PCN, admitting the patient, closely monitoring the patient and removing the PCN as soon as possible. So theoretically it's possible, but practically giving a chemotherapy is very, very difficult.
So maybe you may choose these strategies for a select group within the whole scenario.
Yes.
This patient underwent radical cystectomy with ileal conduit and there was a bulky disease, nodes positive, PT3A, N2, M0, LVI present. So I think we come to, in the MDT, to Dr. Amit only.
So I think, so the take all for this patient, since the patient has not received the any sort of neoadjuvant chemotherapy, whatever the data we have analyzed and whatever we have seen, that even if the patient is even not fit for cisplatin, and if there is a possibility of delivering the carboplatin, we may consider, because there is just nothing to lose because the patient, the surgery has undergone.
So moreover, this patient probably because of the bleeding, as said by Dr. Hemang Bakshi, had to go ahead with a cystectomy.
Yeah, so if cisplatin is not possible, the best is to consider a cisplatin based adjuvant chemotherapy, because there is a good enough data that if the patient has not received NACT, cisplatin, you can consider for adjuvant cisplatin in this case. But even if cisplatin is not possible, I may consider for carboplatin also in this case. And with currently available data of the nivolumab as an adjuvant, that will come into the picture. Although the follow-up is just short, but still in patients who are affording, definitely a discussion should be done for because the FDA has approved the nivolumab in that scenario. So we must discuss regarding the adjuvant nivolumab in this scenario, at least in high-risk patients.
One small question. You have been giving adjuvant therapies to post-cystectomy patients. Your comment on post-op recovery, and do you feel there is a delay?
Yes, so in a day-to-day practice, what I have observed that best to wait for 4 to 6 weeks, because if you trying to give the chemotherapy early post-recovery, it's a supra-major surgery. Patient general function is not well, albumin is on lower side, their PS is not, so better to wait and let them recover fully. Then so I think 4 weeks time is good enough.
So maybe they will get better and tolerate also the chemotherapy.
And the patient should be sent to nutritional counseling and all that. The family member should be motivated so that when he comes for next follow-up, he should be fit enough to start the chemotherapy.
So this is a question, like you already said, dose-dense MVAC, but in the adjuvant setting, you would prefer?
So if we look into the Vesper data, they have the same DDMVAC. It was basically a perioperative trial, but most of the patients received the neoadjuvant chemotherapy, but some patients received the DDMVAC in the adjuvant also. So if possible, DDMVAC, but from the administration point of view, CISGEM seems to be better.
Okay. Suppose if your patient responds good, is there any role of maintenance here?
In an adjuvant setting, if the
there
patient,
is no role.
As such, maintenance means just like adjuvant, as such there is no maintenance, it's a adjuvant in form of maintenance.
This question is to Dr. Ananya. You have seen the histopathology report and we have given adjuvant chemo here. Or in the MDT, what would be your decision?
So I think it's clear that there isn't any level 1 evidence for adjuvant radiotherapy, but there are clearly clinical studies. Certainly the one that Vidang's running at Tata is a trial that I would put this patient into, if I could. If not, then I think it has to be a frank discussion with the patient as to the advantages and disadvantages of having adjuvant radiotherapy. So there may be an advantage for improved local control, although with N2 disease, this man is likely to become metastatic despite all the adjuvant treatment. But there is also likely to be an increase in toxicity. And if this man isn't going to live very long, then there's a question of whether he wants to live that life with toxicity.
Sure. I think we just had a very nice presentation from Dr. Gagan Prakash about it, and the randomized control trial is being handled at Tata Memorial Hospital. I'll skip this. These are the guidelines. Coming to our next case, 58-year-old male underwent RCIC for a PT1 G3 TCC solid October 15, and this was the report. PT3A PN1 MX 1/8 0/6 node positive. A PET scan being done, no metastatic disease. Patient was given adjuvant 6 GEM-CIS, and on is so many cycles okay, Amit?
No, it's a 4 for the cisgem in a new adjuvant. It's the 4th cycle which is recommended.
So this was adjuvant.
So adjuvant 4.
So 4 cycles. So again 6 cycles were given here. On a routine post-op follow-up, there was a right iliac node here, 1.5 centimeters. And a PET CT done shows multiple metabolically active enlarged abdominal retroperitoneal bilateral common iliac nodes here. Few tiny lung nodules but no appreciable activity. And retroperitoneal node FNAC metastatic high-grade carcinoma. So patient did go for alternative therapy for some duration, which occasionally happens in our practice, and then represented with right lower leg edema, severe pain in right flank, sonography showing right hydronephrosis, hydroureter also. There are nodes in the retroperitoneum possibly compressing the right ureter. And because of the obstruction, there is something like a slight right-sided subcapsular urinoma also. Pelvic nodes which are highlighting with the thing. So now, Dr. Amit, this patient had got Gemcis 6 cycles. So these are the questions. Reintroduce, use new therapy. Should we check for PD-L1 receptors? What is your take?
So I think theoretically since the time period from the previous chemotherapy is more than 1 year, so what in a practice we take 1 year. If the patient has received adjuvant or neoadjuvant within 1 year and the disease recurrence, then it will be labeled as a platinum refractory. So if the time period is more than 1 year, theoretically we can reintroduce the chemotherapy, but practically in this scenario, the cisplatin might, because already there is a hydronephrosis and all that. So in this scenario, I will like to go ahead with some sort of decompression, and if otherwise fit, we will try for a carboplatin gemcitabine rather than cisplatin in this case. If the chemotherapy is practically out because of any other associated region, creatinine is not coming down even after PCN, then we'll consider for a second line immunotherapy either with Pembro or at the Nivo. These are the two drugs. Regarding the PD-L1 receptor positivity, as such the second line approval for these two agents are irrespective of the PD-L1. Although the patients who are PD-L positive, they will do better. But as such, it's not mandatory, so we routinely not do that. Molecular subtyping at this point of time, as previously discussed, with the availability of the ardafitinib, the FGFR mutation will come into the picture. So if the patient is affording, we should consider for doing some sort of a molecular testing in this patient at this point of time.
So Dr. Prashant, just a small question to you. Do you get such scenarios for molecular testing?
So I'm not a clinician.
I'm sorry.
So I'm not able to answer the question.
No problem. So we'll take Amit's opinion that we do send for this, and I think most of the questions here Amit has already answered. So this patient was started on nivolumab instead of a second line GC, and took 4 cycles, pain disappeared, a follow-up PET CT was done, and it shows almost very good response, complete response to 8 cycles of nivolumab, which was given in 2017. So I think I have to come back to Amit. What do you think? Continue, wait,
yes.
Holiday?
So the ideal answer is that there is as such no data to stop, but the practical thing what we do, and I have done in few patients, that if the patient is responding well, we like to continue for at least 2 years because that is the duration arbitrarily taken into the RCC trial. So I discuss them and continue for 2 years, and then I usually consider for stopping before 2 years. Definitely, ideally it should continue, but practically 2 year minimum period.
So since, as Amit said, it's not clear, this patient was given a drug holiday, a PET CT repeated, and it was fortunately normal. So the question was, what do we do now? We do follow-up, and a PET CT a year later has a right inguinal node with a SUV of 3. I'll slightly go faster here. He has again a right lower leg edema, FNAC negative, but we all know that such FNACs may be at times not representative. Again, advised follow-up and a PET which shows FDG avid node, which is SUV 6.33. Biopsy. Excision biopsy done. Sinus histiocytosis, no evidence of malignancy. So he was treated in slightly old times. What would we have done today? You said some of the things already, like if there would have been a 1 year gap, I would give a GC and then probably same. In case you would have to use an IO, which one?
So I think since at this point of time, he has received the chemotherapy in an adjuvant setting. So I think the same would we have done at this point of time.
Almost same.
Almost same. The FGFR we could have done. That is one thing, because there is a target.
Molecular typing could have been one thing.
Could have been done.
So it would help to decide therapies, give some counseling,
yes,
predictions.
Because the FGFR positive tumor might not respond to the immuno that well. So as such, if it is positive, we usually defer or avoid giving immunotherapy in those subgroup of the patient. But since the drug is not available right now in India, still is not very commonly we are doing. On compassionate basis, we have started in 2 or 3 patients.
Sure. We have actually 2 small cases, but we are nearing almost the end of time. So, should we? Anybody time? That's it. So we'll stop here. I thank all my panelists. Thank you for. I hope the discussion about locally advanced as well as metastatic was of some use to everybody, because this is what we have generally, a multidisciplinary forum which should be ideally there, and people should jointly think what can be the best for a patient. Thank you so much.
So now we come to the plenary session, and the chairpersons for that is Dr. Shekhar Patil and Dr. Rawal. Can somebody call Dr. Rawal? He was here around. Dr. Shekhar Patil? So I think we can wait for a minute for Dr. Rawal to come.
You are what areas? अच्छा यहाँ भी प्लेनरी में अच्छा यहाँ भी he's somewhere in plenary system.
Dr. Rawal? Or is he? Yeah. So I think till the time Dr. Rawal is coming, I can request Dr. Ganesh to. Yeah, there he is. So I would request Dr. Rawal to introduce Dr. Badrinath Koneti for the plenary session.
Sorry, there was a press event and Dr. Shekhar Patil and me both were there. So he is still there. I'll start the session. And I think about Badrinath Koneti, everybody knows. He is a great friend and he is a great academician. He was in Minnesota, University of Minnesota. When I saw him first time, I had gone to his center. Then he came to Chicago, and then he has gone back to Minnesota. And you have heard him in the morning. He's a great speaker and a very good teacher. And he is going to speak now in plenary on optimizing the outcome in muscle-invasive bladder cancer. Can I call improving and functional and survival outcome in muscle MIBC? Can I call Dr. Badrinath Koneti, please? Sorry. Thank you.
Hi, morning. Thank you, Sudhir. Thank you, Shekhar, for the opportunity again to share some thoughts on how to optimize management in patients with muscle-invasive bladder cancer. Great to see the previous panel discussion as well. I think it's important that we all work together as a multidisciplinary group to attack this group of patients. This is slightly old data, but it's still important. These are 2 graphs that show disease-specific survival and overall survival in patients with muscle-invasive bladder cancer. On the left side, the 2 curves, one is from the 90s and the other is from the early 2000s. And you can see that group 1 is from the early to mid 90s, and group 2 is from the early 2000s. And you can see overall survival is the same, but disease-specific survival is really diverging and continues to diverge. We're really not that much better off over time. And this trend has continued. I think with newer therapies, things are getting better, but we still have a ways to go in improving the lives of patients with muscle-invasive bladder cancer. At least in the US, the economics of bladder cancer are also not great. I mean, this is also slightly older data that we published, but if you update these numbers, the average annual cost, per year cost for a bladder cancer patient in the US is about $15,000. That's from diagnosis to death. Bladder cancer is the most expensive cancer to take care of in the US because patients get diagnosed and then they could have non-muscle invasive disease and last for a long time, or muscle invasive disease, and even then a fair number will have several years worth of survival and lots of investigations and therapies. So it's an expensive disease to treat and lots of pharmaceutical costs, and the costs are higher in women in particular, at least in the US. And this is true across the US. Doesn't matter if you're in the, in a rural town or in New York City, it seems like it's still the same pattern. And this is just from one state. Millions of dollars are spent in bladder cancer care annually in the US. The other thing that's important for us to recognize is bladder cancer can be a bellwether, a complication bellwether for how you manage other urologic cancers. If you manage bladder cancer really well, those centers also tend to manage kidney cancer and prostate cancer really well. The other way around is not true. If you do really well in prostate cancer or kidney cancer, doesn't necessarily mean that you're going to have good outcomes from bladder cancer in the same center. And this is some data we published that shows in places that do no radical cystectomies, the outcome from nephrectomy is about 70% worse. Outcome from prostatectomy is 50% worse. So really, when you manage bladder cancer patients who are very complicated, you can translate that learning and knowledge across other urologic cancers. And it's important for us to recognize that. What predicts complications in patients with bladder cancer? This is in particular patients who are undergoing cystectomy, but could also apply to patients with muscle-invasive bladder cancer who are undergoing other treatments. Older patients, as we all know, more likely to have complications. Large urban teaching centers tend to have lower rates of complications. And primary or surgical complications are less likely to occur in high-volume hospitals in younger patients and in women. We know if you do more of something, you're going to be pretty good at it, and the urban centers tend to have higher volumes. But secondary complications are less likely in younger patients as well as in these same large hospital settings. That's because secondary non-surgical complications are also better managed with more experienced places. And nurse ratios are important because bladder cancer is a very nursing-intensive disease, particularly patients who are undergoing cystectomy. But in general, when we say high-volume hospitals are better, when you do a lot of something, why is it better? Well, only about half of the improvement is because of us surgeons, and saying that this is because surgeons do a good job with the surgery. More than 50% of the benefit in high-volume centers comes from other things like having a good ICU, having good chemotherapy, having good radiation therapy, having good interventional radiology, PET scanning, diagnostic radiology, all of these things. So it's really important if you want to maximize outcomes from bladder cancer care, particularly cystectomy care, you need to have a lot of other supportive team that is also excellent and very high functioning. Just good surgery is not going to get us good outcomes. What about chemotherapy use? We heard a little bit earlier about the standard of care and high-level evidence supporting the use of neoadjuvant chemotherapy. We've known that for over 20 plus years. We understand that in well-selected patients, the impact, particularly in patients who achieve a complete response, can be excellent. But not everybody is going to benefit. We understand if you take all comers, the advantage of neoadjuvant chemotherapy is more modest, but it is still real. It's 5 to 7% in everybody, but in people who respond or well-selected patients, it may be better than that. Luckily, we are seeing increasing use of neoadjuvant chemotherapy worldwide. And interestingly, there continues to be a persistent use of adjuvant chemotherapy that stayed stable over the past 20 to 30 years. And adjuvant chemotherapy also has a role in some specific settings. What about timing of cystectomy? Particularly in muscle-invasive bladder cancer, if you decide somebody needs a cystectomy, then you need to do that within 3 months. And there's lots of data now suggesting that the timing is important because you avoid delay in surgery itself. In the UK, as many of you probably know, I think the time to cystectomy is even lower. It's about 60 days or so. But the conundrum is, if you're going to give people neoadjuvant chemotherapy, then what you do? Because you have to wait for 4 months for the neoadjuvant chemotherapy to work. So now you're delaying the cystectomy beyond the neoadjuvant chemo. In those cases, it's important to study whether the patient is responding to neoadjuvant chemotherapy or not. And at least in my practice, I get a PET scan before, and I get a PET scan and do a cysto after a couple of courses of neoadjuvant chemotherapy. If there is response, we'll continue. If there's absolutely no response, we don't continue. We also select out using molecular diagnostics and see if patient has a molecular profile that suggests potential response. So if this is a patient who does not have a molecular profile supportive of response to chemotherapy, and if the patient is not responding after 2 cycles, you can stop. And that is still just about 2 months into it. And if you're using dose dense and WAC, it may be even a little bit less. So you're not sacrificing that 3-month time window for the cystectomy. It's important to have parameters and do good surgery. So making sure you do a thorough node dissection is important. Making sure you get negative margins is important. And particularly soft tissue margins are a big problem in the time of cystectomy. So I've been taught that if you have a positive soft tissue margin after cystectomy, that equals death, basically, because most of those patients will die. So as a surgeon, it is very important that we get a negative soft tissue margin after a cystectomy, and that's going to be important to make sure that your surgery is of the highest quality. But despite the best hands, complications are going to occur. This is one of the surgeries that is associated with the highest number of complications, no matter which center you go to. I mean, this is data from a whole bunch of different centers, including high-volume centers like Sloan Kettering, USC, et cetera. It doesn't matter. Everybody has somewhere between 30 to 60% rate of complications. So we shouldn't be ashamed if we have complications. Thankfully, only 15% of the complications are serious. Most of the others are minor, so it doesn't matter. But at least gives us an idea what the range should be and where one is. But this also, focuses us on how to reduce the complications. Because one thing to say the complication rate is high, but how do you reduce that? And one of the ways we can potentially reduce at least some of these complications is the use of enhanced recovery after surgery protocols. These protocols were really developed for colorectal surgery, but now have been widely used for many other surgeries, including bladder cancer and cystectomy surgery. And what ERAS uses, and maybe many of you are using it already, but for those of you who don't know, ERAS typically means that patients get no bowel prep. We don't do any bowel prep for any of our patients before cystectomies. There's no go lightly, I usually use just an enema to make sure that the rectal vault is empty, but other than that, no other bowel prep, no antibiotics. High-calorie drinks the day before. They can have clear liquids until 2 hours pre-op. No NG tube. Early ambulation, we try to get them out of bed right after surgery. Early feeding, they just go straight to clears and regular. We don't wait and starve them at all. We use Alvimoplan, take out the drains as quickly as you possibly can, and intraoperatively restrict fluids. We try to tell the anesthesiologist not to use too much fluids, because particularly the pelvic veins, they get very full, and if you get into them, they'll keep bleeding. So if you actually reduce the venous pressure, and we run the patients intraoperatively at very low pressures if possible, even systolic pressures. We try to keep them at 60 to 70 if possible. If the heart is healthy, if not, you may have to go to 100, but we use epidurals and other ways to really reduce the pressure to decrease the likelihood of bleeding. Now, once you're done, you can immediately put fluids into them and get the pressure up. Most patients tolerate it just fine, but you need to work very closely with the anesthesiologist to run a good ERAS protocol, particularly that's intraoperative. But does ERAS help everybody? So at least in our own analysis, we studied this in about 400 cystectomies, and what we found that in patients who have low levels of comorbidity, interestingly, we thought it would help patients who have high levels of comorbidity, but in patients who had lower levels of comorbidity, it made a big difference. Almost 2 days in terms of length of stay reduction, so they got home early, and lower complication rates as well. But in high comorbidity patients, it did not help as much. The biggest factor that made the most difference in these patients was use of Alvimoplan. This is, as you know, an oral agent that prevents binding of opioids to the gut receptors, so it prevents prolonged ileus, allows early restoration of peristalsis, and early return of bowel function. So you don't need to put NG tube, you can feed the patient earlier, and they start moving the bowel sooner. And as we saw, at least in our own analysis, we had no ERAS, then we did ERAS without albumin, and then we added albumin, and the only time we saw a difference was when we added the albumin. One thing to keep in mind, I mentioned all of this management of fluids, intra-op and post-op. One thing that does result because of that is a higher likelihood of having AKI, or acute kidney injury, immediately post-op. So some of these patients will have a creatinine that goes up in the first 1 or 2 days after surgery. So you have to be careful in these patients and make sure you watch for that. The other thing I don't do is clip the ureters intraoperatively, no matter how fast you do the surgery. If you clip the ureters, many of these patients may have underlying renal dysfunction. You can have a sudden hyperkalemia. Particularly in robot cases, it becomes a big issue because you also have renal pressure that delays venous return to the kidney. So typically I try not to clip the ureters, let the urine flow, and also try to keep the operative time short, so you're not, especially in robot cases, as short as you can to avoid renal dysfunction in these patients. The other thing that seems to really help is immunonutrition. So I typically put all of my patients before cystectomy for a week to 2 weeks of impact. You just give them 1 can of boost or 1 can of impact. These are L-arginine rich supplements, and just 1 can a day for about 2 weeks really helps. This is data from a randomized trial done in Kansas, which showed a significant decrease in postoperative complications, particularly infectious complications. We did the same thing. We only did it for 5 days every day, and this also showed decrease in complication rates, decrease in the need for TPN. The most important thing was it decreased post-op infection in these patients. This is not unique to the cystectomy population. This has been used for Whipple's and other GI surgery for a long time. So there clearly is a benefit to using the immunonutrition in these patients. The other thing you need to watch out for is thromboembolic complications. The VTE, venous thromboembolism, can occur at a high rate in these patients. It's important for you to be aware of that. And so what we routinely do is start with heparin before surgery and continue for a whole month. And this is the data that suggests the incidence of post-op DVTs and PEs are significantly lower in patients who get prolonged thromboembolism therapy. One other thing I do typically is always get an ultrasound before cystectomy, because about 16% of these patients, even if they get no neoadjuvant chemotherapy, will have subclinical DVTs. Important for us to recognize that. If I find one, I'd put an IVC filter, do the cystectomy, and a month later take out the filter. If they've had neoadjuvant chemotherapy, almost 1/3 of these patients will have undetected or detected thromboembolic events, typically deep vein thrombosis, and so you need to watch out for that, otherwise they'll get a PE post-op. The other big thing is the impact of the robot on complications and other parameters. These are data from the first randomized trial that compared large-scale oncologic outcomes in patients undergoing robotic versus open cystectomies. All patients had extracorporeal conduits. The primary endpoint from the RAZOR trial, which was led by Dipen Parekh, was to compare oncologic benefit or non-inferiority of oncologic outcomes. So the premise was whether you got robot or open cystectomy, oncologically there would be no impact, and both patients would have the same progression-free survival, which was proven in this study. So oncologically there's no difference between robot and open. There was slightly lower length of stay in robot cases. Estimated blood loss was lower in robot cases, but OR time was longer by almost an hour in the robot cases. Now, this is data from the IRCC, led by Khurshid Guru from Roswell. And they now have over 4,000 or 5,000 patients in this data set. And again, they also showed the same thing. Robot cystectomy reduces blood loss, decreases transfusion rates, slight reduction, typically about a day less in terms of hospital stay, but complications are no better. So unfortunately, at least the early data suggests that doing robotic surgery for cystectomy does not reduce complication rates. And this is if you do the whole thing intracorporeally, if you do cystectomy and the conduit or neobladder intracorporeally, again, the same findings, less EBL and so forth, but, and type of diversion doesn't matter. Whether you do an extracorporeal or intracorporeal really does not seem to affect complications or mortality. And to really answer the question of whether doing everything completely intracorporeally can gain an advantage, the IROC trial was done by Jim Caddo and colleagues in the UK. Interesting trial, one of the first of its kind, really well done study. The problem was they had to stop early because of COVID, and they only got follow-up in about 305 of the 371 randomized patients. But what they found also was that there was a length of stay difference by about 1.1 days. So again, very consistent, whether it's retrospective data, RAISE, this, all of that. You can reduce stay by 1 day if you do a cystectomy robotically with open diversion or intracorporeal diversion, doesn't matter. Still about a day benefit overall. About 89% of the diversions in the IROC trial were all conduits. No difference in complications, whether they did open or robotic, there was no difference. Quality of life, there was slight difference in a couple of quality of life parameters. The WODAS, basically looking at the self-reported disability score, patients felt stronger, and also they had more stamina early on. This was a group of patients who underwent robotic cystectomy and diversion. And the open group, it took them about 12 weeks to really recover completely. Most of the other quality of life parameters, no difference at all time points. So it's important that this was one of the main findings of the trial. There is a slight benefit to doing a completely intracorporeal diversion and cystectomy robotically in terms of quality of life. Patient reports less disability and maybe earlier return of stamina and strength at 5 weeks instead of 12 weeks. Otherwise, really not a big gain. And the RAISE trial that we were part of, along with Dipen, showed no difference in quality of life in the robot versus the open. So when you compare the two trials, and I think these are some of the best evidence we have on the impact of robot in cystectomies, suggests that robot cases take longer. That's not surprising, we know that. Length of stay, about a day less, whether you do the whole thing intracorporeally or not. And complications, no different. Quality of life, maybe a slight advantage if you do intracorporeal diversions. Maybe patients recover in a couple of parameters at 5 weeks. So actually, even the IROC trial, if you look at the discussion, the conclusions, they also are very modest in their claims and are very muted in their boasts of advantage of the complete intracorporeal diversion. So though I'm a surgeon and I love to do robot surgery, we have to look at the data to say, yes, there's some benefit, but perhaps not as much as maybe in kidney surgery or prostate surgery, particularly with cystectomy. And I think that's inherent because of the disease itself and the major nature of the case that we're doing with the cystectomy, which affects two different organ systems. It affects the genitourinary organ system and the GI system. All the others, where there's a lot of benefit, with robot surgery affects only one system. So when you, I think, transect two systems, you cannot get the same benefit. Then a word about trimodality therapy. I think we heard Ananya's here. Hi, Ananya. Great to see you. And so she's one of the experts on this, so it makes me feel really, quite embarrassed to be talking about trimodality with her in the audience. But a great discussion earlier as well, and good work seems to be underway here too. But this is, again, data from the MGH group. Now they have, this is one report. I think they've got a few more updated patients now, but almost 500 patients over from 12 trials over 27 years. So they've been trying for a long time to convince us that trimodality therapy is a good option. And actually it is. This is the long-term survival data. 50% of the patients survive, have good disease-specific survival. Overall survival really is no different from patients undergoing cystectomy. And as you can see, in the time period since they've been doing trimodality therapy at MGH, you can see progressively the response to chemoradiation has improved. It's almost 88% complete responders now. The overall survival has improved. The risk of salvage cystectomy has declined. And the bladder intact disease-specific survival has gone up from 40 to 75%. It's almost doubled. So, I mean, clearly this works. If you pick the right patient, it makes a lot of difference. And so one of the key things here is to perform a visibly complete TUR. And you can see that over time, the visibly complete TUR rates, at least in the MGH series, has gone to 83%. So they're making sure that we take out every bit of tumor as you can. You have to practically do a partial cystectomy endoscopically to make sure that you're doing a good job. And in patients who have more than clinical stage T2 disease, they tend to do a little worse than patients who have T2. Complete response to radiation and chemotherapy, as assessed in the MGH group after the initial set of radiation, seems to really help predict those people who are going to do well. Absence of hydronephrosis is also a good sign. And presence of CIS, particularly if it's there before and also comes back afterwards, also is a predictor for subsequently needing to undergo a cystectomy and may have an impact on disease-specific survival. So it's important to select the patients well, but if you do, then the outcome can be good. There's some data using just population-based reports that suggest that the outcome may not be as good in the general population as seen at centers of excellence like MGH. So there is, and this is one analysis of publicly available data that suggests that trimodality therapy survival was a little worse than cystectomy. But I think it's important to note that some of these other series, the treatment and the patient selection was not standardized. So we have to make sure we're comparing apples to apples. One thing I will point out, if you do a really good job of selecting patients based on all the criteria that at least are used in the US, very few patients would really be great candidates for the trimodality therapy. But in the UK, they're more generous in their patient selection and will offer trimodality to more patients. So at least in the US, oftentimes we do tend to send patients who are too sick for cystectomy, but we tend to choose patients who have small tumors, no CIS, no hydro, no lymphovascular invasion, ideally tumors that are not at the ureteric orifice, no upper tract disease. Complete TUR should be possible in these patients, and then of course they should be able to tolerate cisplatin. Though, based on Nick James and some of the UK trials, 5-FU and MITO can also be used, which can be used in patients with poor renal function as well. You can also use different tissue markers that are emerging to better identify patients who may be good responders to trimodality therapy. This is not mainstream yet, but lots of promise in finding some of these gene expressions that may help us guide who will respond to trimodality therapy. At least the most recent AUA guideline basically strongly recommends that patients with muscle-invasive bladder cancer who elect multimodality bladder-preserving therapy should be offered maximal TURBT, chemotherapy combined with external beam radiation. And the EAU guidelines and the NCCN guidelines all endorse use of trimodality therapy in this group. There was a lot of concern about quality of life with the radiation that is given to these patients. This is data that we published looking at cystectomy patients, which ultimately, after about 6 months, regain a good, stable quality of life. Original prospective studies suggested there was some concern with quality of life in patients undergoing trimodality therapy. But if you look hard at the more recent analyses and long-term data, it suggests that general sexual and bowel function preservation is pretty good after trimodality therapy. They may have more urinary symptoms, which is understandable, but the quality of life is not as bad as perhaps with the original series. So just to conclude, I think when we take a look at all the data available and we try to apply that into practice, improving bladder cancer care, particularly for patients with muscle-invasive bladder cancer, can yield high bang for the buck, because I think cystectomy is a key canary in a coal mine, at least in management of urologic cancer. So as urologic cancer surgeons, we need to really do well after cystectomy, which will then translate to how we manage other cancers as well. Peri-op management and post-op care are critical to get good outcomes. And the robotic approach has a measurable but modest benefit, and we should keep that in mind. And we really need to think about trimodality therapy as a viable alternative in well-selected patients, because it preserves quality of life, particularly in some of these patients who place high importance on that. So we should not forget that. Thank you again for your attention.
Thank you, Badri. We have time for questions. So first, I will ask, then I'll open the house. My always question has been on NACT in muscle-invasive bladder cancer. I still remember in 2005 when we conducted first Uro-Oncology conference in Delhi, and my friend who is no more is Chris Wood. He came and he did one neobladder. He said in his center, all the patients, they go for NACT. And I think more high volume center like MD Anderson, MSKCC, they were giving NACT, but the Sears data were only 10% at that time. Now it is 40%, and you see other country, it has not picked up that well. We are now giving in 30% of the patients, but I have noticed a few things which I would like to clarify you because of your experience. One is that the patient who have T3 disease, on PET scan, they have sub-centimeter node which are actually having uptake. These patients have not seen such a very good response. I may be wrong, but that's what my feeling is. But when I operate them, Second is, even if the T2 disease with squamoid differentiation and the glandular differentiation, these two situations, what is your suggestion? Because when you operate them, then many times you find the residual disease. And the best candidate, which probably I have seen, is the patient who have T2 disease, who receives NACT, either actually N0, PT0 disease, pathological complete response. So in three situations, what is your comment and what do you suggest?
Yeah, no, I agree with you actually in all of them. Let me start with the last part. I do think if patients who have a complete response are basically cured, I think they'll be the best patients and most benefited by neoadjuvant chemotherapy. That's why it's important for us to find out who are those patients who are going to get the complete response and then really strive to better select out. And that's where I think molecular diagnostics and other things are going to help. In terms of patients with the sub-centimeter nodes, I also agree with you. I've had patients with PET scans that are positive. Sometimes you wonder if those are truly, sometimes they're truly metastatic nodes or what those nodes really represent. Or maybe there's a different clone that is not responsive to the neoadjuvant chemotherapy. I've had patients with metastatic nodes in the mediastinum, in the supraclavicular area, and we go out and, I've taken those out as well sometimes just to see what these are because we don't know what to make of the PET scan, these patients. And squamous, I don't think responds to neoadjuvant chemotherapy. Glandular, the question is whether you have, it's just predominantly urothelial with a small component, then you may still be able to get benefit. Because Ed Messing did a study with a retrospective analysis of the SWOG trial of neoadjuvant chemotherapy. And funnily, he found that if you take away patients who had squamoid or adenomatous differentiation, all the difference between the two groups went away. So that has never been shown in any other study, but there is some question whether these patients who have these variant differentiations, depending on how much of the variant is there, whether they can respond to chemo or not. But squamoid, I usually tend to also not be a big fan of neoadjuvant chemotherapy.
Yes, Vedang. Oh, sorry, Makaran, then Vedang.
Excellent talk, Badri, as usual. Just two things I wanted to know. What about varied histology? Have you learned anything in variant histology? Have you progressed anything in last 2 decades? Have you done any sort of progress, number one? And secondly is, yes, all the urologists I think now are convinced that NACT is the sort of way go forward. We are doing it. Second thing, trimodality also I think we know it's working. But there is a significant problem in patients who have undergone trimodality. I agree that if 1 in 3 used to get a cystectomy, the number has gone now. A lot of bladders we can save. Problem is the post-op follow-up. They need a long-term follow-up, long-term check cystoscopies. Also sort of, the bladders look sometimes horrid with the post-radiation, whether they have disease or not. And the chance of a second malignancy, maybe in the prostate or somewhere else. I mean, these are slightly concerns of trimodality. So views on variant histology and the concerns what we have for trimodality.
Sure. No, both, again, as usual, Makar, very insightful questions. Variant histology, I think we're learning more and more. Some of the variant histologies, particularly micropapillary, for example, we are realizing that some of them do respond to BCG. Some of them do respond to neoadjuvant chemotherapy. Originally, when micropapillary came out, we said they're not going to respond to anything, just take out the bladder. But now I think you can select out some patients, depends on how much micropapillary is there. Some of the other variants, particularly nested and some others, are so aggressive that maybe some of these treatments don't work. Sarcomatoid, maybe and carcinosarcomas, some of these small cell variants, typically surgery is not the first option. Chemoradiation may be a better option for these patients. So I think we're getting to the point where we are better able to select out some of these, but some of them we still don't have any answers. I mean, plasmacytoid is a classic example. I mean, every one of my patients who had plasmacytoid has died. I mean, there's just nothing you can do for these patients. Chemo, radiation, and nothing seems to work. So more data needs to be obtained, and we need to do more. I do think in terms of neoadjuvant therapy, I'm increasingly encouraged by the combination of neoadjuvant immunotherapy, immuno-oncology as well as chemotherapy. At least we've published our own data and some other groups have come out. I think the combination is going to yield much higher responses and maybe work in some of these tumors that have got EMT and neuroendocrine sort of differentiation as well. And in terms of long-term follow-up, you're 100% right. I think you need to make sure these patients can be followed up. Otherwise, you cannot really just do trimodality and let them free because it's important to follow them up.
Vedang and then Saurabh. That's Vedang.
Dr. Koneti, excellent talk. Thank you very much. On your slide about the ideal patient for trimodality, the first point is something that I'd like to humbly disagree with. You said the sick patients who are too sick for cystectomy, I don't think they'll do well with bladder preservation either. I think the ideal patient is the one who is very fit for cystectomy. They are the ones in which we are going to get the best outcomes and best bladder preservation rates. There are enough data, younger patients, fitter patients who can get chemo, who can follow up properly, will do well. So that was my comment.
No, I think you make a very good point. I totally agree with you. I think the idea of putting too sick is because that's who we send oftentimes, unfortunately. Historically, we look at all the data, right?
Yes.
Maybe they're not ideal, but ideal from a surgeon standpoint is for cystectomy because we cannot do the cystectomy. But yes, you're 100% right. The young people will do just as well.
Thank you.
Yeah.
So what is your opinion about the role of adjuvant chemotherapy in post-cystectomy cases where patient was eligible for NACT but has not been offered to him? Will it going to be decided based upon the biopsy finding, or will you like to give it to all the patients, number one? And number two, what is your opinion about the role of CX bladder test in cases of post-BCG surveillance?
I'll answer the second one quickly. We don't have data on post-BCG with CX bladder. I think they're looking to see if they can get, but that study has not been done, at least not to my knowledge. In terms of adjuvant chemo, I think adjuvant chemo has a role, but the data are not strong. So we don't have as good level 1 evidence, but we still offer adjuvant chemo in some of these patients. But now with good level 1 evidence for adjuvant IO, it makes it easier to perhaps use IO or maybe IO in combination in these patients. But adjuvant GC or adjuvant MVAC is also a totally reasonable option.
Should we offer to even in that condition where the margins are negative and the lymph nodes are also negative, or we should only offer to those patients where the margin is positive or the lymph nodes are positive?
Yeah, I would say probably more patients who have some pathologic characteristic that needs chemotherapy. So typically if they have N+, then that's when you would offer them adjuvant chemotherapy.
You will not like to give it to all the patients?
No, I don't
if they have missed the NACT?
Correct, yeah.
So thank you, Badri, again, and it's a great talk and great to have you here. Thank you. I with Dr. Shekhar Patil, who could not join because of there was a press event, so I thank all the organizers, Raghu and everyone, and we will proceed now for inauguration. Thank you.
Thank you, sir. We are going ahead with the inauguration session right now, and so far I think we are having a very good session since morning. It is on time. We will have inauguration now, followed by the SOGO oration, and then we will have a talk by Dr. Yuvraj, which was actually missed yesterday because we were pretty late yesterday in the end, and then we will break for lunch. You will have to go.